Good morning, everybody. It is approaching the top of the hour, 9 o'clock. So I will go ahead and kick off with opening remarks for our 2024 SEOW Symposium. My name is Malcolm Dotson. I will be your MC for today's event. Before we get started, I just wanted to ask, did anybody lose a large roll of $20 bills with a rubber band? Because I found the rubber band. As I said, my name is Malcolm Dotson. I am the account manager and research associate with Syra Health. I've been with Syra for about a year now, this past May. My background is in public health epidemiology from Purdue, where I received both a BS and MPH. I would like to start off this event by introducing our CEO, Dr. Deepika Vupalanchi, for opening remarks. Dr. Vupalanchi is the co-founder and chief executive officer of Syra Health. Prior to starting Syra Health, Deepika obtained her doctoral degree in molecular biology and genetics from the University of Delaware. She continued to work as a research scientist for renowned institutions before moving to the private sector. Working in the healthcare industry, Deepika gained experience in many areas, including healthcare strategy, education, and outreach. She worked in leadership roles for global pharmaceutical companies, government agencies, and managed care entities. Dr. Vupalanchi co-founded Syra Health after realizing a lot of healthcare services are a one-size-fits-all model, when in reality, healthcare solutions need to be integrated, customized, and cost-effective. Ladies and gentlemen, please welcome Dr. Vupalanchi.
Good morning, everyone. I think I found a $5 bill. Anyways, it's an honor to welcome you all to this year's State Epidemiological Outcomes Workgroup Symposium. As we gather to address mental health crisis in Indiana, it is essential to recognize the profound impact mental well-being has on our communities. Recent statistics highlight the urgency of addressing mental health concerns across all age groups in our state, making our work today here more critical than ever. Indiana's current 26th ranking in the nation for the prevalence of mental illness underscores the necessity for innovative and inclusive solutions that reach every individual. In response to Indiana's growing need for comprehensive mental health solutions, Syra Health is thrilled to introduce Serenity, our pioneering platform designed to empower mental well-being through timely and proactive intervention. It's been a pleasure managing the State Epidemiological Outcomes Workgroup for the past 3 years. As we move forward, let us continue to focus on prevention. Research indicates that earlier we intervene, the more significantly we can reduce the incidence of severe mental illness. In closing, I would like to extend our deepest appreciation to the FSSA's Division of Mental Health and Addiction and the SEOW for their unwavering dedication to improving Indiana's substance abuse prevention policy and their invaluable work recommending prevention priorities for the state. Thank you for being here today. Together, we will ensure that no one is left behind in the pursuit of mental wellness. So thank you and enjoy your day.
It is my pleasure to introduce our first speaker this morning, Brianna Dines. Brianna is experienced in community engagement and mixed methods applied to research, specializing in qualitative data collection and analysis through community-based and academic roles. Her skills include community outreach and stakeholder engagement and thoughtful, contextualized, and utilization-focused analysis for clients. She is passionate about community power, economic democracy, and quality of life, and works to center community lived experience in research, informed planning, and decision-making. Prior to joining TPMA, Brianna administered work plans for 6 neighborhood communities, facilitating grassroots community leadership and placemaking across 12 projects, coordinating events for an environmental nonprofit focused on changing quality of life and ecology along Indianapolis waterways and surrounding neighborhoods. In addition, she managed communications, translating scientific and technical information into digestible content for the public. She has also worked as a research and teaching assistant in the social sciences at multiple institutions. Ladies and gentlemen, please welcome Brianna Dines.
Hello, everyone. Good morning. Glad to be here representing TPMA and to share with you some of our evaluation findings from DMHA's older adult and youth prevention grants. So as he said, I'm Brianna Dines, but I am by far and away not the only one involved in this project. We've got a full team at TPMA managing, just managing up to 43 sites, keeping in contact with grantees and making sure they have what they need. But we also have worked with Montreal Partnerships, doing program observations, NetLogix helping us schedule all those site visits, and then also Bingo Research Group to do some broader state level survey analysis. So what we've done in terms of evaluation is combine an implementation and outcomes evaluation, which the implementation kind of focuses on the process and experience of implementing the grant. And of course, that outcomes focus on the results and those pre-post tests to kind of demonstrate the impact. So that includes kind of individual sites, which might have multiple programs, multiple schools, or multiple community partners, and also, rolling that up into an aggregate state level as well. So our activity included, obviously, ongoing communication, as I mentioned, that outcomes data collection analysis with those pre-post tests, site visits. Those were made up of staff interviews, but also the program observations, and annual subgrantee and state level reporting. So it's a pretty impressive numbers here. So 75,282 served through individual-based strategies. And those individual-based strategies are the direct programming that are, in schools or sessions with older adults. Population-based strategies are those media campaigns and other population level approaches. So this will be shared. I won't go through all these numbers with you, but you'll have access to that kind of grant breakdown there after today. So for older adult prevention, each site has their outcomes tailored to their specific context, their community, which is important, and what's established in their work plan goals. But there are some common outcomes across outcome measures across sites, and those include expanded knowledge of how to manage medication use, understanding of addiction, improved ability to identify factors that might put them at risk, signs of alcohol abuse, and other things, and importantly, connecting older adults to services and resources as well. Okay. So with the WISE program, which is Wellness Initiative for Senior Education, we see an increased knowledge of medication safety, for example, and that includes these statements: being aware of the dangers of prescription drug abuse, how to safely store them, see an increase there. Behaviors like reading the instructions about over-the-counter medication, and also, knowing what to do with prescription medication when you're done with that. If you will notice, so the N values do vary, and that is because we're looking at across subgrantees, where some might have, because we're modifying surveys for each context, some might have one question or not. So that's where that varies slightly. Okay, so if we look here at perception of risk, so we see some pretty dramatic increases, positive increases with risk, so including over-the-counter medication, prescription medication, as well as alcohol. So moving on to youth prevention, again, the sites develop different target outcomes for their specific context and their community, but these are some common ones. At a base level, kind of increased knowledge of what substances do to their bodies, increased kind of peer pressure resistance skills, decreased favorable attitudes towards substance use, perception of risk as well, along with older adults, increased resiliency skills and self-image. So those are some of the kinds of things from just basic facts to, how do they perceive substance use. So we chose the life skills training program to highlight. It's got kind of the most data, the most kind of specific. And so for middle school students, we did find that they were more, after the life skills program, they were more likely to refuse substances. And, that includes cocaine and other drugs, cigarettes, marijuana, and alcohol. Little bit less dramatic increases here for the high school students refusing substances, including, vaping, alcohol, marijuana. The most pronounced positive results were vaping, alcohol, and marijuana. Less change for some of these others, and even, slight increase for cigarettes. So, it's interesting between middle school and high school students. High school students are farther along. They, they're older. They've kind of, they're less influenceable, less malleable than younger kids. More resistant to influence, and are encountering some more messaging, access to other kind of messages that they're seeing in social media and other things like that. So perhaps that accounts for some of the less pronounced results here. Middle school students were also more likely to have healthier attitudes towards substances after the program. So these statements, just a reminder, so the percent who disagreed with these statements, so higher percentage is good. So we see a little bit of an increase here for some of those attitudes, such as drinking alcohol makes you look cool. Smoking cigarettes lets you have more fun. Kids who smoke have more friends, these kinds of things. Okay. So with high school students, mixed results for attitudes towards substances after the life skills program. Again, we see that there are some increases that we do not want here. So, for example, smoking cigarettes lets you have more fun, which is interesting. But for the most part, for the most part, we see across the life skills program improvement overall. So I'll switch to some of the qualitative findings. So these were generated by site visit interviews with grant staff and facilitators at each site, which I see a couple here. And we used those transcripts from those interviews and with staff and facilitators to do an inductive thematic analysis using a grounded theory approach. So that's just taking the content of the transcripts first, reading through, immersing yourself in that data, and coming to conclusions, developing patterns across sites based directly from that data, rather than kind of assuming content before. Okay. So one thing that we found qualitatively was a lot of sites had data collection challenges. some sites reported lower reading comprehension and lack of attention among young people in particular. So, maintaining attention to just complete a survey, but also, some of the wording that came with some of the developer materials we had to massage so that students could understand and we could get real, actual good data. Some sites cited, COVID learning loss as part of the reason for that. But, we work with sites to kind of modify that to make sure we could get as good a data as possible, while also trying to, balance that need for comprehension and flexibility with consistency. Several sites also reported this year some added and varied procedures in schools, and that may have been across, one site may have had several different ways that they needed to collect data and so, there was some new legislation, but there's also, again, those kind of comprehension and attention challenges as well contribute to, how we need to modify things to make sure data can be collected in the way that schools and other partners will be comfortable with so that we can get that data and use that data. So, sites may have had to deal with a little bit more tailoring the process to each school as they kind of respond to new situations. In addition, so particularly rural sites and those working with older adults did encounter, in trying to do community needs assessment or just, make programming decisions based on data, we're kind of confronted with just a lack of sufficient data to confidently make those decisions or be able to kind of lay out the landscape comprehensively. And so some, as represented in this quote, are, trying to fill that gap themselves so that, as they move forward in their programming, they can make decisions based on some solid data that really speaks to their community at their level. Another finding we had was just challenges serving diverse communities. There, a few sites, needed to adapt to serve LGBTQ plus youth. Some sites were hoping to address factors for this group, but came up against safety concerns for public events and community pushback. So they had to find other ways to provide services for this group. Also, the increase in linguistic diversity in communities as represented by the quote here, that maybe in areas that had previously not had a lot of linguistic diversity, just challenge sites' ability to serve everybody because of the need to have translations or the lack of availability of interpreters for those languages. And in addition, rural and older populations do have significant barriers that are distinct from more urban or youth-serving sites. So that includes transportation. In a rural area, it's just hard for people to get places. There's, not a bus system, that's reliable, or it's cumbersome or expensive. And also, with older adults, they also have some transportation issues as well, but also, of course, health issues and just comfort in weather. We hear a lot that, when it's colder, when it's rainy, you might have less participation that day because it just doesn't feel good for them to get out. So all the sites essentially had really spoke to the successes that partnerships bring. And that may not be a super revelatory finding, but partnerships do bring success. So among those is increased visibility, credibility, and reputation. So building trust in the community through, especially newer sites or smaller organizations that are, partnering, they gain trust and credibility by being associated with already trusted partners. Partner relationships supported broader community connections. So that kind of, we're talking data here, so I can use snowball. It's almost similar, analogous to snowball sampling. It's like if you've got a partner and that relationship is good, then, you're going to be able to connect to even more partners and really broaden your network and your foundation for community-based work. And then it's just on the ground expanded implementation. So as sites, they have their own facilitators, but also partnering with others and, the trainings made available through these grants with DMHA, they were able to, get additional facilitators so that it wasn't just all on their organization. And they could kind of distribute the work of facilitating these programs throughout the community a little bit more. And that, speaks to sustainability as well, because, when you're not just reliant on a couple people to carry out the program, you've got more solid basis for sustainability. Okay. So the next steps for us are doing our final grant analysis across all the sites for this year, for this grant year, fiscal year 2024, and also reporting for the entire grant cycle. So fiscal year 21 through 2024, we're excited to dig into that and see, kind of what's happened over the course of these several years. There's also, because there's so many different grants and sites are at different stages, there's also, not a perfect level of consistency year after year as sites, again, kind of address their own context and community as needed each year. But we think we'll find some interesting things this year. So thank you so much for listening. And I hope you found that helpful and informative. Again, I think the slides will be available after today. So thank you.
Thank you, Brianna. I did want to note to everybody, there is a Q&A session after each speaker. So if you would all like to step forward at one of these two mics and ask your questions, feel free to do so. Next, it is my pleasure to introduce Doug Hunsinger. Doug serves as the Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana and is the Chairman of the Indiana Commission to Combat Substance Use Disorder. As a senior advisor to Governor Eric J. Holcomb and a member of the governor's cabinet, Doug oversees the coordination of the governor's Next Level Recovery Initiative, aligning and focusing the state of Indiana's response to the drug crisis. He also serves as a member of the Justice Reinvestment Advisory Council and the Governor's Health Workforce Council. Organizations across Indiana have recognized Doug for his efforts. The Indiana Judges Association named him the 2021 Champion of Justice in recognition of his work supporting family recovery courts and behavioral health services for justice-involved individuals and families. Overdose Lifeline presented Doug with the Policy Advocate of the Year Award for a steadfast commitment to serving our most vulnerable Hoosiers, and Thrive Recovery community organizations recognized him for his distinguished service, presenting him with the inaugural State Partner of the Year Award in 2022. Ladies and gentlemen, please welcome Doug Hunsinger.
Well, thank you, Malcolm, and thank you for the opportunity to share the progress that we are making statewide on the behavioral health front. We have emerged from a historic year of investments in our behavioral health system. We're using over $30 million of the state's share of the National Opioid Settlement Funds. We've entrusted locals to bolster the statewide treatment and recovery infrastructure that we've worked the last 7 years to develop. And this includes the addition of 440 new beds and recovery residences, the implementation of 8 new harm reduction street outreach teams, and the expansion of behavioral health initiatives in our state's judicial and correctional systems. And a little over a week ago, we announced a new funding opportunity to expand the certified peer recovery support workforce. These were all priorities that we have outlined in our initial $52 million plan to spend the state's first distributions of our opioid settlement funds. And as we get closer to spending down that initial plan, we're beginning to develop future plans for the next few years. Our commitment to widespread naloxone distribution continues through Overdose Lifeline, distributing over 24,000 doses of naloxone to Hoosiers for free statewide each and every month, thanks in part to our 200+ grassroots distributors. We've invested over $86 million to build our crisis system, anchored by 3 pillars: someone to call, someone to respond, and a safe place for help. Since launching Treatment Atlas in this last September, Indiana's addiction treatment locator, more than 21,000 Hoosiers have accessed the site in search of quality care. Recovery hubs and cafes have sprouted across the state, serving as a front door for individuals seeking treatment, while simultaneously working to help navigate those transitioning out of treatment, providing ongoing psychosocial supports and connections to resources to facilitate long-term recovery. These efforts, and so many more, have contributed to an 18% reduction in overdose deaths since 2023, the second highest decrease in the nation. Over the next 7 months, it is our goal to position communities for success. As new dollars continue to flow into local units of government, collaboration will continue to be the key to our success. Indiana is positioned to receive $918 million across the next 18 years from settlements with opioid distributors, manufacturers, and marketers. And that doesn't even include the anticipated Purdue Pharma bankruptcy. It also doesn't account for the millions in federal dollars received each year, including the State Opioid Response Grant, Addiction and Mental Health Block Grant funds, and the CDC's Overdose to Action Grant. With these resources, Indiana is poised to continue to make significant strides in the years ahead. Over the last 7 years, we've equipped communities with the tools to develop and enhance a collaborative and evidence-based treatment and recovery infrastructure. In some communities, that means starting from scratch, and in others, the players were already there. They're just not talking to one another. We've seen countless examples of success, whether it's Dearborn County, where in 2017, with the support of Lawrenceburg Mayor Mulan, they started a TI ROSC and have since opened a recovery hub, deployed an emergency response team, and their justice system has coalesced around IRACs. Their work to get local buy-in from the beginning has led to cooperation among all the stakeholders and fostered their innovation. In Clinton County and the city of Frankfort, county commissioners and Mayor Sheets have created a model of local cooperation, forming an interdisciplinary committee to determine how to spend their settlement dollars collaboratively and effectively to fill gaps within their community. And the Lutheran Foundation in Allen County, an early adopter of collaboration, brought together stakeholders like the Fort Wayne Police Department, Project Me, Parkview Health Systems, and the Allen County Health Department to create the Hope and Recovery Team. HEART is one of the first overdose response teams in our state, following up on non-fatal overdoses and connecting individuals and their families with resources for treatment rather than arrest. At the heart of each of these initiatives is collaboration. Now, collaboration is not something that you can fund. Believe me, we've tried it many times. But collaboration is the foundation in which we build healthy communities. For us to continue to drive down overdoses and support individuals with mental health issues and substance use disorder, justice involvement, and support their recovery, we must collaborate. Now more than ever, we're entrusting locals with the responsibility of leading initiatives, providing them with the structure and the funding for community-driven solutions. Health First Indiana is the culmination of recommendations from the Governor's Public Health Commission to enhance local public health funding while at the same time maintaining local control. The counties that have opted in for 2024 are receiving a combined $74.6 million in Health First funds. And all 92 counties are expected to receive an additional $150 million for fiscal year 25. At least 60% of these funds must be spent on core services identified by the Indiana Department of Health. These range from student health, infectious disease prevention and control, emergency preparedness, fatality review, maternal and child health, among many other services. So where does mental health and SUD fit into all of this? While not explicitly written into the core public health services, there are connections to them within the Health First Indiana funding, one being trauma and injury prevention. For example, looking at the local health departments as they're engaging in their community and regional partners in coordination with harm reduction for substance use, such as naloxone distribution, peer recovery, rehabilitative services, prevention activities, infectious disease testing, so that if a county looks at their data and sees that, for example, drug overdose or suicide is a leading cause of harm in their community, then yes, they can use Healthy First Indiana funding towards those preventative or interventive activities. Another core public health service where this intersects is access to linkage to care. Being able to have individuals and resources to connect to partners in the community who can provide mental health, overdose, or substance use related services. Counties can and also have been advised to leverage their opioid settlement funding to support these activities in their communities and work with their partners to be able to provide all of these services. All of this information, including the county scorecards and the funding breakdowns, are available at healthfirstindiana.in.gov. A key contributor to a healthy state is mental health. And we've made huge advancements in the mental health space, transforming Indiana's behavioral health system to better serve our most vulnerable Hoosiers and create a linkage to care between behavioral health care and other community pillars. Since implementing the 988 crisis and suicide lifeline in 2022, our in-state answer rates are consistently in the top 5 nationally, connecting Hoosiers in need to not only someone to call, but someone to respond and a safe place to go. To date, we've invested over $86 million in the creation of mobile crisis teams and crisis stabilization units. FSSA and DMHA have submitted their application for a federal demonstration waiver to pilot a new model of care for behavioral health through the certified behavioral health clinics. Crisis care is one of those 9 core services provided by our CCBHCs. So when you hear me talk about the intentional investment that we're making in crisis infrastructure, it won't be possible without CCBHC expansion and its enhanced payment structure. Investing in crisis services pays dividends not just in the mental health healthcare system, but in the justice system and our greater healthcare system as a whole. Our historic investments in the public and mental health will mark this era as a pivotal moment for the future of our state. And we're not just talking. We're actually working together to understand the touch points and the systems that we're building, and then conversely, how those systems have an impact at the local level. We have important work to tackle, and no single entity in state government or at the local level bears sole responsibility for that work. And that's why it's so important that we collaborate at all levels. Across the country, we're seeing the fruits of our collaboration in the fight against substance use disorder. The CDC recently announced an estimated 3% decrease in overdose deaths nationally for 2023, the first decline since 2018. As we enter the final 7 months of Governor Holcomb's administration, we should take a moment to recognize how the work we've accomplished in Indiana has become a model for other states and contributed to this national movement. I hope that what I was able to demonstrate is how we're not just tackling the drug epidemic. We're working to expand access to mental health supports, to care holistically for an individual, to build cooperative system that improves outcomes for all. It is so important that leaders at all levels of our state understand that we will not have a growing economy without a healthy workforce. I'm incredibly proud of the progress that we're making on all of these fronts, but we're not finished yet. Thank you for your time today. Thank you for all that you do for our state, because only together can we make Indiana a better place for all Hoosiers. Thank you.
Thank you, Doug. Next, I would like to introduce Dr. Muni Begum. Dr. Begum is a professor of mathematical sciences and the director of data science and analytics at Ball State University. She has about 2 decades of graduate teaching and research experiences in the fields of statistics and biostatistics. Dr. Begum supervised over 40 graduate research thesis projects and published in top peer-reviewed statistical journals. Her primary research interests are in developing statistical methods with application to biomedical and health science fields, and has keen interest in big data, predictive methodology, predictive modeling, models for correlated responses, multivariate techniques, Bayesian methods, hierarchy modeling, and survival analysis. Dr. Begum serves the Addictions Coalition of Delaware County and the Center for Substance Use Research and Community Initiatives as the Director of Data Analytics. Please welcome Dr. Begum.
Good morning, and thank you, Malcolm, for this kind introduction. And thank you for the invitation to this annual Indiana SEOW Symposium. It is my pleasure to present some results from a work in progress project where we are trying to find high need areas. And this is perfect timing for this talk, as the last 2 speakers set the stage for what I'll be presenting. So before I start, I would like to acknowledge the collaborators in this project, Dr. Devraj, Shrikant Devraj, Mr. Jason Collins, and Michael Paul from Syra Health, and my graduate student from Ball State University. So here's the outline of my talk. Basically, I will give you a brief overview of quantitative analysis that we use to find counties in the state of Indiana. Those are, we can say that whether they are vulnerable in terms of substance use disorder. And to do that, based on the available data, we picked 3 substances, opioid, as you have heard already, which is one of the substance that Indiana has a public health issue, has crisis. And we also looked at stimulants, combined some of the stimulants and looked at overall risk for stimulants, and finally synthetics. So these are the 3 substances that I primarily considered in my analysis. So what I will do, I will give you a brief introduction, which has already been set, but I will go over that and a background. And I will show you the sources of data, the variables, information that are used in the analysis, and the method, a quantitative method that we used, and mainly talk about the results. The results are not confirmed yet, since there are some limitations in the data, which I will also discuss. And I'll summarize and give you what we will do, what future direction we can take from here. So as we all know, substance use affects Hoosiers a lot. right? And so the focus is to identify geographic areas, those need attention in so that we can implement preventions. So to identify quantitatively based on the data, based on the available literature. So that's the main focus. And as I mentioned, I focused on 3 substances, again, based on data, based on whatever data we have. So we have this opioid, which is the bigger one, and then some stimulants. We combined cocaine, heroin, and other stimulants together. And then we also looked at synthetics use disorder. And as I said, the goal is to find the risk, like which counties at the county level, geographic areas. Our goal is to find which areas are at high risk for this substance use disorder, so that prevention methods that we have heard can be applied effectively. And how we did that, the quantitative analysis involved calculating what we called SUVI, or Substance Use Vulnerability Index. So that's one metric that we calculated. How we did that? We used a systematic regression weighted ranking approach to calculate vulnerability index for each county in the state of Indiana. And these are the substances that we considered. And again, to give you for completeness, opioid use is the major issue. There are some other issues, as we have seen from the first presentation, alcohol use. And in our analysis, we also considered other substances such as marijuana, heroin, meta, I can't even pronounce that. So some of the substances, because what we found that there is another issue, sometimes you see correlation among these users. So I will talk about that later, like what you can call like polysubstance disorder. So that is another issue that can be addressed, and which is, I noticed that instead of looking at one substance at a time, we can we can consider them combinedly. So that is another issue which I will briefly mention, that is like for future analysis. And again, why this opioid become an epidemic? It started with pain relief, and then people grow dependence. Similar issue with synthetic opioid, which we also included in our analysis. And this is another issue that I noticed while doing this analysis, while calculating the vulnerability indices, that we can look at dependence pattern among the substances. So that is another another statistic or another avenue we can take a look at. But that will, that again, I put as a future direction. So our future analysis. So let me focus on the current analysis, where the goal is to find high need area. And the metric that we used, we calculated vulnerability indexes for each county. And the data sources that we considered are these 6 sources. IDOH, Stat Explorer, of where we have the outcome or response variable, which is overdose-related deaths. So opioid overdose death, or synthetic overdose death, or stimulant overdose death. So those are the 3 outcome variables that we considered one at a time. And then rest of them, are some of them, rest of the information are what you can call like covariate or explanatory variables or predictors that will explain why we are seeing these overdose deaths came from the rest of the 5 sources. And so as I said, the outcome of interest, like the what we are interested in, opioid, we looked at by itself, and cocaine, heroin, and other stimulant we combined because of sparsity of data. We combined them into what we called stimulant, and then synthetic because we had enough data, so we analyzed by itself. And here is some, if you can read, I thought I will just give you some summary statistics of these 5 response variables. And you can see again that cocaine, heroin, and synthetics, these are sparse from the numbers. One interesting number is like any opioid, you can see there is maximum number of deaths for a county is 604. And you can see the number is high for synthetics as well. And for the middle 3, we combined when we analyzed them. And you can see, you can either look at the median and the first and third quartile to get a sense of variability, or you can look at the standard deviation, that there is a lot of variability across counties. Remember, these are county level data that we are considering. And here again, the distribution, you can see for some outcomes, like the first panel is the overdose deaths from any opioid. You can see this high at the right side, there is a point that indicates the maximum data point. And there, for all of them, there are some maximum values, but most of them clustered from 0 to, say, 10 or 20. So that is our outcome variables. And to calculate VI using the regression approach, we need covariates or other predictors. And we considered some core, what in the literature they call core indicators, that you keep those indicators in calculating the index, and some other information that maybe that could be correlated with the outcome. So we have we considered 4 core indicators because there are 1 or 2 for which we did not have complete information. So we had to exclude that from the analysis. And number of like 20 other covariates or predictors based on the literature. For example, whether people have access to internet, whether people have a diploma when they are 25 years old, and whether they're dependent on some of the other substances. So number of information we considered. And you can see the 4 core indicators include opioid-related arrest or any other substance. When we considered stimulant, whether the arrest was related to that. And income and emergency department visits related to that particular substance, and also prescription dispense. And again, these are some of the statistics or summary on these core indicators. And you can see that emergency visits is high. The maximum is more than 2,500. The other interesting thing is arrest and also opioid dispense rate with high variability across the counties. And I thought it would be nice to see how these core indicators correlate with the outcome variables. So here we have, I just looked at the overdose death from any opioid and these four indicators. And you can see the first one is arrest. There is positive correlation, and the bottom at the bottom panel, first one is arrest, and the other two, medium income and dispense rate, is not that correlated. So arrest and the emergency visit is positively correlated. And so I just looked at these statistics on alcohol use, and I mean, not just alcohol, the other substance use and dependence across the counties. And you can see on average, alcohol and meta something, so those are on average higher in terms of use. And then dependence, same statistics. And you can see when we are looking at, and these are, by the way, these are percentage of substance, these 5 different substance uses and dependence. So this is just to give you an idea at the county level, what is the scenario of how the use and dependence. And I think this would give us some information when we are calculating the vulnerability index as well. So we add these, actually we just add one of these, the use, substance use, percentage of substance use in the vulnerability index calculation as predictors with the other covariate information. Okay, so those are like some summary that I wanted to present. And now the method that I used. So notice that overdose deaths, these are counts. You can calculate rate as well, but to consider a regression model, we took the counts and we considered a model which is suitable to model such count data, and that is known as negative binomial regression model. So if you paid attention, we have a lot of covariate information, a lot of information that we used. We thought those will explain the overdose death. So, but those information may be correlated among themselves. So we had to do something. We used what is called VIF, or variance inflation factor, to take out some of the correlated information. We do not want two predictor or two information that give you the same information. So we did something using VIF. And then what we did, we kept all core indicators. Remember, there were 4 of them, and only statistically significant covariates to calculate our vulnerability index for each county. And I was looking at the correlation structure among the outcome variables themselves, just to give you a nice graph. So remember here, notice that here we have like overdose deaths from any opioid, cocaine, heroin, stimulant, and synthetics, and the middle 3 we combined. But I was looking at how they correlate among themselves, and you can see they're highly correlated. So if we look at one at a time, that won't give us the entire picture. So once I was staring at that graph, and I thought, okay, what I did may not be enough. We need to look at them altogether, which is which we will do next. And I also wanted to see like emergency visit, if there is any correlation, and there is also correlation, highly correlated among when people go to emergency department for these substance uses. And yeah, I just wanted to look at if there is any correlation among dependence as well. There is not as much as in the overdose death. So again, these pictures, I thought these are these give us nice information about the right analysis method that we can use. So this is just my observation that since all the outcomes are highly correlated, maybe just a negative binomial regression model, taking one outcome at a time, may miss some of this correlatedness among themselves. So we can look at extensions later on. But the results that I'm going to present based on the one stimulant at a time. So remember, we are finding risk, how vulnerable counties are based on what is that? Overdose death from opioid and from stimulant and from synthetics. So what we did after fitting the regression model, we took the regression coefficients as weights, and then the information, the predicted information that we consider, like the core indicators and other significant information, we take their rank for each county and combine them to calculate the vulnerability index. And then we put this index into a map. And that this map is created using what is called quantitative geographic information systems, or QGIS. So here, one thing you notice that these 92 counties are classified into 5 groups, where each group, depending on the scores are vulnerability scores are ranked. So you can see the darker counties are more vulnerable, okay? And each class has the same number of scores, meaning that same number of counties. If you want to take a look at the top scores for opioid overdose death, you see Marion, LaPorte, Allen, Delaware, St. Joseph. These are the first most vulnerable counties in terms of opioid overdose. And we did the same thing for stimulants, and results are pretty similar. And you can see that the same 5 counties came up as most vulnerable when you look at the when you take overdose death from stimulants. And we repeated that. Remember, we are doing these one at a time. So we repeated that for synthetics. Again, same story, but St. Joseph now went down, and I can't read from here. We have another county that came to 5th position in terms of most vulnerable counties. So basically, that's what we did. Our focus is to address substance use disorders, since it is a major public health concern, and we calculated county-wise risk score, which we call vulnerability scores or indices. And we considered 3 substances, one at a time. And this is what I had been mentioning throughout my talk, that when I was doing the analysis, I thought, okay, we can actually take into the correlatedness among themselves and do what is called a multivariate analysis. So what we saw that the outcomes are correlated among themselves. So we can actually utilize that information that may give us some additional fact, and we will be able to address this polysubstance use disorder, which is another issue, important issue. And I was also thinking about looking at what pattern we can identify across substance dependence. And for that, remember our data, we had data in terms of proportion of dependence. So we can consider regression models for proportions, and then we can look at these, if there is any significant patterns in the dependence as well. And that's all. And here is two references that I used. And thank you all for your attention. I will be happy to answer if there is any question.
Thank you, Dr. Begum. At this time, I would love to offer an opportunity for a bathroom break. So feel free to get up, stand up, stretch. We have some breakfast items across the hall, B and C common rooms, and some coffee as well. Also at this time, if your parking has not been validated, please go outside to the front and we can handle that as well. Thank you, and we will resume at 10:15. Welcome back in, everybody. It is 10:15, and as for our next guest speaker, I have the honor of introducing Jay Chowdhury, the Director of Indiana Division of Mental Health and Addiction.
All right, good morning, everybody, and I'm just gonna sit because it's Friday. It's summer Friday, casual Friday. Well, welcome, I guess, on behalf of DMHA. I appreciate everybody's participation, and thank you so much to Jeannie and her team for putting this together. If you've seen me speak before, I like to tell stories, and I had to speak yesterday and not tell one, so I'm gonna tell two today. So just buckle up. Thankfully I have a call at 10:30, so I'm not going to be up here talking at you forever, but there was this police officer walking his beat, okay, at night, and he sees a guy on the ground, and he's clearly looking for something, right? He's on his hands and knees, crawling around and, looking, and the officer says, "Sir, is everything okay?" And he says, "Oh, yeah, I'm just trying to find my keys." And the officer says, "Well, where did you drop them?" And he points and he says, "I dropped them in that tunnel over there." And the officer says, "Well, why are you looking here?" And the guy says, "Well, the light's better here." So file that one away. That's story number one. Okay. Well, stay tuned. The second one's shorter. It's about animals, fun with animals. My kids are kind of past the animal phase, but I kind of miss that phase a little bit. So it's about the seahorse, right? So and I've heard this, I've not verified it, so it could be completely wrong. So if you're a marine biologist, please don't at me, as they say. I'm just telling the story. So when the scientists are studying the health of an ocean or ocean ecosystem, there's obviously a million different things they could study, right? They could look at the pH levels or the algae blooms or the, a million other things, right? But what they tend to do is they look at the health of the seahorse population, right? Because they know that the seahorse population and their health is an indicator of the overall health of the ocean ecosystem, right? So let's use these two things together. Okay, so the first question, when we talk about data and we talk about sort of our CCBHC future and we talk about where we want to go and where we want to get to, the first question we have to ask ourselves is like that guy looking for his keys, are we just looking where the light is, right? That's question number one. And question number two, I think, is equally or more important, and that is, are we looking at information or data points that actually tell us how we're doing, or are we just looking at them to look at them? And that's really, and so, when we think about CCBHC, and I see, Wendy's here, and so, hey, Wendy, raise your hand, wave. And Wendy is our data guru here at DMHA, and she, so let me just explain kind of what CCBHC is and how we're using data and how we're using those two questions and making sure that we're incorporating that in what we're doing. So CCBHC is, and again, if you heard this before, you can tune out here, but is a new model of care. And it's, one that we're kind of all in on with our community mental health system transitioning to this new model of care. And it does a few different things, but basically it's a new way of paying for care, right? So we can pay for care based on what the actual needs of patients and communities are, as opposed to, as it currently stands, we kind of pay for care based on what the funding streams are. And that payment model is a really important piece, obviously, of the transition. But the other really important piece of this transition is data and data transparency, because we're going to have to report consistently a lot of different measures to the federal government. And the measures that we have to report sort of allow us to answer those two questions, right? It makes us look at the right things, right? It makes us look at time to care. It makes us look at, how are people accessing care? It makes us look at actual outcomes as opposed to like outputs, right? And it makes us look at things that are indicators of the overall health of the system. So every quarter when we report to the federal government, we're going to know how our system is doing. But in order to get there, right, and Wendy, I don't want to talk about all the things you're doing, but in order to get there, it requires so much work to get our systems there. And so that's why I think as we talk about data, and I think it's like this is a good lead into Orman's presentation afterwards, like as we talk about data, as we talk about transparency, as we talk about reporting and all the other things that we're talking about, like let's keep these two things in mind. Where are we looking and where are we not looking? Where are our blind spots? And what is what we're looking at telling us? So that is all I actually have prepared, but we were going to open it up. If there's any questions about kind of DMHA or our vision or our direction, I got a few minutes to answer them. So there's some mics here. I got one of them here because I wanted to sit down, but feel free to chime in. If not, it's can end and I can go jump on my call. I should say I didn't schedule a call at 10:30. I scheduled one at what I thought was 11:30, but it's in a different time zone. I got that wrong. So that is why we have this sort of tight turnaround, because I apparently am unable to coordinate time zones appropriately. So any questions or comments or observations? It's ask me anything, so be whatever. Where did I get my shirt? I got my shirt at our 988 storefront, which you can access. This is a 988 shirt. 988 is one of our big initiatives, and we ask you to, we'd encourage you to go and support. That was a question I got earlier, so go ahead and repeat it for the audience. Yeah, wonderful question, Orman. So, our main metric for 988 is in-state answer rate. Right. So this is so 988 is a 3-digit number for suicide response and crisis prevention. People in crisis dial 988 and they are connected to one of our 4 in-state call centers, and those call centers either answer the call, and if they don't, it gets transferred to a national backup. So I'm proud to report, thanks to Kara Byro and Lindsay Potts and a lot of really wonderful leaders at DMHA and also our call centers, that we have consistently been in the top 5 in-state answer rates, usually in the top 2 or 3, which means that Hoosiers that call 988 know they're getting answered by people that know the state and know the resources and understand, kind of what's going on. So we're proud of that. Data gets tricky with 988 beyond that, right? Because one of the cornerstones of 988 is anonymity. We don't ask people for anything other than what they feel comfortable volunteering. And so, as we think about those two questions, right? Like, what are we missing and what are our blind spots and what is it telling us? Those questions have become a little harder to answer with 988 because, kind of fundamental to the, to the model is anonymity and sort of a person's safety and comfort comes first. And so, that's it. So it gets interesting, it gets tricky. I think there's states that are doing some things, and we've done a little bit of this, of kind of examining de-identified transcripts and seeing if we can pull out trends. Nationally, they're going to more of a geolocated approach, which is complicated from a privacy standpoint as well. So I think if and when that rolls out, we'll be able to know more. We do know that our call rates are going up, which is simultaneously, terrifying, but also gratifying because, that means that people who need help are seeking it. Now, I think the fact that it's going up means that, we have some issues, some work on the demand side of the equation, which is a much bigger conversation than we can probably solve in this room. Yes, and so I should say that 988 to us is just the tip of the spear. It is sort of the foundation of a comprehensive crisis response system that includes mobile crisis and crisis stabilization, right? So someone to contact, someone to respond, and somewhere to go. And our crisis dashboard will kind of encapsulate all three of those pillars. Yeah, it's a great question. Thank you for bringing up the unhoused population, which is, I think, one of our, not just in Indiana, I mean, sort of around the country, kind of one of our biggest challenges. It's kind of shameful, frankly, that we have, not in Indiana and nationally, that we have as large of an unhoused population as we do. And I think the drivers of it are kind of complex and involve, housing stock and mental illness and addiction and all kinds of different things. As far as where, our coordination there, I do think we are coordinating better as a state and local governments than we have in the past. There's a few things during COVID, for example. We partnered with a lot of local governments to launch safe recovery sites for unhoused folks to be able to recover from COVID safely. And so that has resulted in some pretty good collaboration. And so we've also funded what are called low barrier shelters in a couple of different places for folks to go into. And then we're in conversations, not just we, but the state and the city are in conversations in Indianapolis to do a similar thing for Indianapolis. All that to say, I do think the coordination around unhoused folks and homelessness is not nearly where it needs to be. And I think, that applies across the board, whether it's coordinating people into the continuum of care system with housing or coordinating around data. I mean, our best data for homelessness right now is the point in time count, right? Which is all it is a point in time. How many people were homeless, observed to be unhoused at a certain point in time. And that becomes sort of the driver of everything else, that data point. And is that accurate? I don't know. I mean, I think both of those questions so both of those questions come into play, right? So what are we missing, right? And what is it telling us? And I think we need to do better on that. I don't have any answers for you, but I think we do need to do better. And I think a lot of people are around the country are wrestling with those same issues. It's purely voluntary. Yeah. So I can get back to you on that. I don't know off the top of my head what it is. So, but it is only what people feel comfortable. For demographics. Yeah. Yeah. And it's tricky, right? Because I think like when somebody's in a crisis, and this is true, like not only with data, but also with like insurance and crisis response, right? It's like, obviously we want as much as possible to leverage insurance and other Medicaid and other commercial insurance sources to pay for some part of crisis response. But the last thing you want to do when somebody's in a crisis is like try to figure out what their insurance is and what they're eligible for. And so it's one of those unique things to crisis response. So I got time for one more. Thank you for that question. Yeah, well, I think a lot of them are sitting in this audience today. I think the collaboration between the state and the recovery community and treatment providers has been, I think, second to none. Everybody's laser focused and specific things that we've done. Harm reduction. Harm reduction works, right? I know it's getting a bad rap, right? In different places around the country. Getting saturating the state with naloxone and in creative and novel ways is definitely working. And it is a lot easier than it used to be to get into treatment in Indiana. Is it as easy as it should be? Of course not. We're always going to be striving to make that better. But we have, and Doug probably mentioned on the numbers. I mean, we've increased residential beds by, several 100%. We've increased, access to different treatment options. We launched Treatment Atlas, so we have a treatment locator. So if somebody takes that step of wanting help, then we're able to meet them where they are. So I think collaboration, access. and then commitment from the leadership, from Governor Holcomb all the way down, I think are probably the three reasons. And investment, we've spent money on it, right? I mean, that's seems obvious, but we can't forget that, you know, in order to move the needle on these things, we have to invest in them. And so I think we're starting to see that with behavioral health as a whole in our state. I mean, in 2023, we had a historic investment in behavioral health, and we're using that to build a lot of these things. So, but it's a good question. So that's it. I got to run to my meeting. I told him I'll be a little bit late, so I'm okay. Don't worry if you're worried about it. So I believe Orman is next. So I will turn it over to whoever. Thank you.
Thank you, Jay. Truly a pleasure. Before I introduce our next guest speaker, I did want to make a note to everybody that there is a lost parking ticket that is up at the registration desk. So if anyone has misplaced their parking ticket, please go see the registration desk. Thank you. Next, it is my pleasure to introduce Orman Hall as our next guest speaker. Orman served as the director of the Ohio Department of Alcohol and Drug Addiction Services during Governor John Cash's first term. He also served as director of the governor's Cabinet Opiate Action Team, where his focus was on estimating the scope of opioid addiction in Ohio and developing strategies for treatment, community education, and prevention. Prior to his tenure in the state government, he was the executive director of the Fairfield County Alcohol, Drug Addiction, and Mental Health Services Board from 1989 through 2010. He is currently working with SMHSA Region 5 as an IPA contractor. Everyone, please welcome Orman Hall.
So I don't know about you guys, but I'm really relieved that Jay was able to break that participation barrier because I had questions that I wanted to ask. I didn't want to step up to the mic. And I think what we found out here is that the acoustics in this room are sufficient for us to just have sort of an organic dialogue. And hopefully we can do that. And by the way, if you have questions that you held for our previous presenters, I am not going to be at all offended if you want to bring one of those two back up. In fact, I've got a question that I'm going to ask one of our previous presenters. Just real quickly, I'm going to go over some data that is specific to Indiana, but it's all from federal data sets. Now, in many instances that, and let me step back just a minute. When I was in the state of Ohio, I looked at Ohio data from Ohio. And there's some advantages to data that originate from the state that you're operating in. It's going to be more recent. It might be more complete. But let me suggest that there are also advantages to looking at your state's data from a broader perspective also. So just kind of starting here a little bit. And I just selected sort of not randomly, these are data sets that I've been spending some time with, but this is just a fraction. I mean, not even a fraction of some of the data that you could glean at the federal level. But so we're going to look briefly at CDC Wonder, SAMHSA TEDS, DEA NIFLS, and DEA ARCOS. And the reason I selected these data sets, again, I'm spending some time with them, and they are all also available online for your amusement or whatever. But a quick quote from Edward Deming, without data, you're just another person with an opinion. And I hate these trite sayings, but it's true. And the other thing that I would suggest is that we are all in the midst of massive social change that we're attempting to deal with. And some of these changes have incredibly horrendous implications for our society, the overdose epidemic. So we feel compelled to take action. But an underappreciated artifact of us taking action, of us moving forward with interventions, is that every solution that we create to a problem creates additional problems. So if the intervention doesn't fix our original problem, it's worse than neutral. What we're doing is we're we're creating other problems that somebody else is going to have to deal with down the line without fixing the original problem. And I think we're engaging in a lot of that kind of behavior, and looking at data can help us sort of deal with those kind of issues to some extent. So CDC Wonder, and I just have 2 slides here on this particular topic. Just by show of hands, does everybody know, or is everybody familiar with the CDC Wonder data set? Just so I see a hand or 2. Real quickly, CDC Wonder is a mortality data set that is managed by the Centers for Disease Control. My strong suspicion is that for those of you who are looking at mortality data, you're doing it with internal data sets from Indiana, which is fine. In fact, it's really good. But this first map, again, it's from CDC Wonder, from data that was collected here in Indiana. And Dr. Begum, are you still in the audience? Not seeing her, and I hate that because I had a question for her. So this is 10 years of mortality data from 2011 through 2020. It's averaged deaths per 100,000 population for every county in the state. And there might be one county that's suppressed in the sort of central western part of the state. And what the CDC does, and I'm sure what the Indiana Department of Health does, is if there are insufficient numbers that might allow somebody to identify a decedent, or that might create sort of a wrong impression because the data set isn't large enough to make a generalization that could be inaccurate, then the data is suppressed. But this is pretty complete data because it's 10 years worth of data. And what we see here are several clusters of counties in Indiana that have elevated levels of overdose death rates. And again, just by show of hands, are these patterns that you're seeing on this map consistent with your general expectations? I see a few heads nodding. Now, you could have generated this map with Indiana data, but picture, if you will, a map of the United States with all 3,120 counties worth of data, and the choroplectic pattern. So what we would see if we had that data, and I could have done it, but I didn't, and I apologize for not doing it, is we would start to see clusters that cross county or that cross state lines. So the 2 counties on the eastern side of Indiana are close to counties in Ohio that have similar levels of elevated overdose deaths. So it leads us to ask questions and to look for answers to questions that we wouldn't have looked for if we hadn't looked at the data in a broader context. And the same for this county in the that's a little south. I think if I am getting my geography correct, that county is close to Kentucky. Kentucky also has elevated levels of overdose deaths. So therein lies one factor of why it's important or helpful for us to look at data from a federal perspective as opposed to just our own state's data. Now, a quick question. I do a little bit of work for SAMHSA Region 5. There are 6 states in SAMHSA Region 5. Indiana, Ohio, Michigan, Wisconsin, Minnesota, and Illinois. So as of 2022, where would you guess Indiana falls in the continuum of overdose death rates within those 6 states? Just by show of hands, would you guess that Indiana is number 1 in terms of overdose deaths, the highest death rate among those 6 states? I see a few hands showing here. How about number 2? Number 3? 4? All right, so we get it. So there are a number of opinions. So here's where we're at in terms of overdose deaths. That's a jumbled mess. I apologize for that. but you got it. You probably knew, right? You probably, no, that was a guess? Wow, I'm impressed. So Indiana's number 2 behind Ohio, which, you know, in some ways, before I knew this, was kind of flabbergasting. Why would states that are largely rural, like Ohio and Indiana, have overdose death rates higher than Illinois, which has one of the 2 largest cities in the United States? I mean, it's mind-boggling to me. So if you look at this particular chart, you'll see at the very beginning of the period, all of the states are very closely clustered. Indiana is almost at the bottom of that list. But again, look what happens. Very similar patterns overall. And then this drop in the last year for both Indiana and Ohio and several of the states. So Jay did a really good job of identifying factors, interventions that are underway here in Indiana that affect overdose deaths in your state. But let me suggest, you know, if we think about this from a sort of a standard research perspective, we have a dependent variable, which in this instance would be overdose deaths. And then we have, that would be the dependent variable. Then we have a series of dependent variables, which would be those interventions that we engage in to influence the dependent variable. But there are also things that we can't influence. Things like the underlying socioeconomic conditions that exist within communities. And then another sort of underappreciated variable, and I have a little bit of data on this later on, is the drugs, the illicit drugs that people are exposed to in the communities that they live. And what we know from research that we've completed in Ohio is that over time, the illicit drug supply, the drugs that people are exposed to in the communities where they live, vary rather dramatically over time, and that around 90% of the variance in deaths from one year to the next are accounted for by what's in the illicit drug supply. So as we move through this period, there's a period where overdoses are driven by prescription drugs. And then as we start to clamp down on prescription drugs, we see heroin driving overdose deaths. Heroin's a more dangerous drug than prescription drugs are. And then around 2015 or 16, depending on which state you're in, we see fentanyl sort of replacing heroin. And as we look at this chart, we can see if we superimpose those drug seizure data sets that we all have access to, or that many of us have access to, we can see the effects of those changes of the drug supply on overdose deaths. So one other quick sort of anecdotal piece here. In some states, we have seen overdose deaths increase 400%. And there are other states where over this time period of around 2 decades, we've seen overdose deaths increase by more than 1,000%. So given that sort of statistical artifact, what would you guess the change in the number of people using illicit drugs, excluding marijuana, is in our society? Anybody want to hazard a guess? Just shout it out. I mean, 100%? Have we had 100% change? 50% change. Well, the reality is we have almost exactly the same number of people using illicit drugs in 2022 that we had 20 years ago. So the general assumption is we have more deaths, so there must be more people using. And that may be true in some areas, but it's not necessarily true, and it's certainly not true overall in our society. Moving on. So that was CDC Wonder. There's a ton of stuff that you can do with CDC Wonder. And again, from my perspective, the biggest benefit here is being able to put your state in the context of the bigger picture of what's going on around the country. So I want to spend just a minute or two around SAMHSA's treatment episode data set. But again, by show of hands, who's familiar with treatment episode data set? More hands showing up here. That's great. So one of the SAMHSA TEDS data sets that has just now become available, and it's massive, but they have, and I should probably step back and explain it. The treatment episode data set, treatment agencies are required or expected, maybe is a better word, to collect admission and discharge data for people that have been admitted to treatment in their agency. So if you're a public agency, there's a general expectation around doing that. And it has some great data points in it. It has things like primary drug of use, secondary drug, tertiary drug, age of first use, frequency of use. Then there are detailed demographics, the types of services that people are using. It's a great data set. And if you haven't looked at it, I would suggest that you do look at it. So here are a few little data points that are just for Indiana. So this looks at alcohol admissions. So as a percent of total admissions, we see that alcohol admissions have gone down over time. Not surprising. Alcohol is a really serious problem. Alcohol problem in your state, I suspect, hasn't gone down, but there are more pressing issues that most of us are concerned about. So this would be cocaine admissions. Cocaine admissions have also gone down. By the way, Dr. Begum, I'm sorry, you probably raised your hand and for some reason I wasn't seeing you. These are our charts, and I noticed that you're using R in your data presentation too. So this would be methamphetamines. This is probably not a big surprise. And by the way, there's a new process. We don't see shake and bake methamphetamine labs anymore. I've got a colleague from HIDA back there. I'm hoping that is also true in Indiana. You guys aren't seeing those mom and pop methamphetamine labs in Indiana anymore, right? Which is amazing. So based on that information, you would think, well, the availability of methamphetamine is down in Indiana. It is obviously not down. Would you care to share just real quickly why methamphetamine availability is not down, given the fact that Indiana production of methamphetamine is down? Exactly. And some of you may have already known that, but the effect of that, and there's a new manufacturing process that is significantly, that results in a significant decline in the cost of methamphetamine. So the cost is down and the availability is up, and therefore the drug supplies change. And what do we see? A big increase in methamphetamine use in your state. This would be marijuana, sort of a stable pattern here. And this is opioid. So what we see here in Indiana, and it's not a dissimilar pattern, we still see a ton of people, we see increasing numbers of people dying from opioids, but paradoxically in Indiana and Ohio, opioid deaths peaked in 2016 and are now in the decline. So not deaths, use. So if opioid use is declining, why are opioid deaths still going up? Would anybody like to hazard a guess? All right, I'll tell you. If you look at the data, we see increasing numbers of people dying from cocaine and methamphetamine overdoses. But if you look at it really close, those same deaths are co-occurring with fentanyl. And by the way, that shows up in drug seizure samples. In the Ohio BCI data, which is toxicology based, about 20% of the cocaine supply in 2022 had fentanyl mixed in it. Now, but now that fentanyl availability is declining, we're seeing more pure we're seeing less contamination, less fentanyl contamination in cocaine and methamphetamines, which means we have fewer people dying. Anyway, one factor, not the only factor. I need to be careful here. I'm not looking at my clock. Where are we at time-wise? 10 minutes. I apologize. I'm rambling too much. So DEA NIFLS. And I didn't bring HIDA data because HIDA data is not routinely available online. So this is NIFLS data, which is available online from the Drug Enforcement Agency. And what you have here is a list sort of from high to low of the types of drugs that are being seized in Indiana. And what do we see at the top? I think it's methamphetamine. I can't hardly read my slide. So we have methamphetamine and fentanyl, completely consistent with the earlier slides that we saw in terms of treatment. So this particular slide compares Indiana's drug supply with the nation's drug supply. So, and my eyes are old here. So the U.S. drug supply is the blue bar, the Indiana is orange. And so where we see the orange bar exceeding the blue bar, that means that there is more of those drugs in your environment than at the national level. Again, a helpful statistic from the standpoint, if we accept the premise that to a certain extent, a large extent, overdoses are driven by what's in the drug supply, this helps us understand what factors we might want to concentrate on from the standpoint of interdiction in your state. DEA ARCOS. Is anybody familiar with ARCOS data? So ARCOS is one of the other data sets, marvelous data sets that the DEA has is pharmaceutical data that is distributed within each state. And there are a couple components. Data set goes back to 2006. And they have it presented in several ways. There's a list of drugs, I think it's around 20 different drugs, varies from year to year. They have more data than just the 20 drugs that they're tracking. But from the standpoint of the drugs that they do track, we have it summarized at the state level, but we also have it at the 3-digit zip code level. So it gives us an opportunity to look more granularly at the drugs, the illicit drugs, or not illicit drugs, the pharmaceutical drugs that people might be using. What I did was I took methadone and buprenorphine and took a look at the distribution of those two drugs by 3-digit zip code in Indiana. So this would be buprenorphine. And this is at the per capita level. So you can get a sense of where most of the buprenorphine is, which, by the way, is very similar to where the people that are dying live, which is great. That's very helpful. And what we see here is that there are a lot of rural areas where buprenorphine is available. Now, this would be methadone. It doesn't say that, but it is. And you see here some urban centers showing up in the methadone distribution network. So that's the data that I had. Mostly what I wanted to do was to just open your eyes a little bit to other sources of data that might be available that have a, what's the word that I'm looking for? That directly affect some of the things that you're concerned about. And this is just a fraction of the data sets available at the federal level that you might want to look at. So that's my presentation. I think we're at about 5 minutes. 9 minutes. So we have 9 minutes for questions, and they don't have to be just for me. And by the way, I have a question for Brianna. So I'm going to take some liberties as the presenter. Brianna, when you were talking, you displayed some data around cigarettes where on the post-test, students were actually more motivated to think that cigarettes were an okay thing to do. Do you have any thoughts about why that might be? No, my first question is, Was that outside the margin of error? And if it was, what factors might contribute to that particular issue? Why would people be more likely to think that it's okay to use cigarettes after the post-test?
Okay. So my understanding is that is outside the margin of error, that particular one. I would want to confirm it going back, look at that particular question because those end values do vary. But I think it's something that we could dig deeper into to explore, like, what are the associations, the attitudes, the perceptions around vaping versus cigarettes as we see that transition from, the popularity of one to the other. I mean, literally a couple days ago, my 16-year-old nephew said, oh, like somebody I know, like, was smoking a cigarette. And I was like, oh, bro, that's gross. And why are you doing that? And I think there, as somebody with an anthropology background, like my interest goes to, like, what are the cultural associations? What's cool, right? And then that speaks to the attitudes. And it's like, coolness is always kind of associated with, like, not mainstream. So as vaping becomes more mainstream, I wonder if, that is pure speculation. But I think one thing to explore with that are perhaps shifting cultural associations. Like, if you want, if youth want to, and I don't know if it's also correlated to, like, the late 90s and early aughts trending back. Like, is that part of aesthetic coolness in youth culture? It wasn't huge though. So, I don't think we should try to overstate any of those possible things, but it's something that could, I think is beyond what's possible with our prevention evaluation scope, but is something that might be worth exploring more, particularly for the vaping versus cigarettes.
So I'm sorry, go ahead.
Yeah, sure. I mean, I think, mapping availability and concentration. Yeah, that would also be another exploration to think about, to try to understand that difference.
Any other questions or thoughts, please? So we probably have time for maybe one more comment before we go, or before I go. Please, Rich. Oh, thank you. Mm-hmm. Well, that's a great question. So if that question would be specific to TEDS, a treatment episode data set. So there are multiple questions that ask what type of drug do you use? So there would be primary, tertiary, and secondary. And so, and maybe there should be more, but for the most part, I think that's probably sufficient. So what you can do is you can look at the combination of those drugs across those three different variables and come up with polysubstance abuse from that. And by the way, the treatment episode data set, or the TEDS file that I used to create the graphs in this presentation, there are 40 million records in that data set that are online that you can download and analyze to your heart's content. And with that, I think I need to be done so that I don't take somebody else's time up. Thank you so much for having me here. This was fun.
Thank you, Orman, for leading that discussion, truly. Next, it is my pleasure and a great honor to introduce my mentor, our team's mentor, VP of Syra Health, a dear friend of mine, colleague, and one heck of a cricket player, Dr. Shrikant Devaraj. Dr. Devaraj is the chair of the SEOW Outcomes Workgroup and the vice president of health analytics at Syra Health. He earned a doctorate in economics from Indiana University, Indianapolis, within the field of health economics and applied econometrics. Prior to joining Syra Health, he worked as a research economist and research assistant professor for the Center for Business and Economic Research at Ball State University, where he is now a research fellow. He has been published in several leading academic journals with research focusing on public policy, healthcare and health services, and behavioral health outcomes, business and regional economics. Ladies and gentlemen, please welcome Dr. Devaraj.
Thank you. Thank you, Malcolm. So good morning. So how is the day going so far? So just curious, how many of you are attending the symposium for the first time? Great. Welcome, welcome on behalf of State Epidemiological Outcomes Workgroup. We welcome you all here. And for the rest, welcome you back again for the symposium. So as you can see, the day, it's a full day symposium. You'll have a variety of speakers, experts, evaluation experts, subject matter experts, practitioners, from people from academia, kind of giving you a different perspective of data sets that are available. And then it's basically, how do we collectively use the information that we have and then make decision-making at your fingertips, right? So that's the goal behind this particular symposium. Again, welcome you all to this. So I'm the chair for the State Epidemiological Outcomes Workgroup. So just to give you a little bit of background about our workgroup. So this workgroup was established back in 2006. It's funded by a DMHA through a federal block grant. And we have representation from about 20 state agencies, DMHA, Criminal Justice Institute, DCS, IDOH, DOE, Indiana State Police, Department of Corrections, HITA, IU's Prevention Insights, Indiana National Guard, and Management Performance Hub as well. So the goal of this work group is to monitor the substance use, consequences, prevalence consequences, and also mental health and suicide trends in Indiana. We do track existing literature and then look for emerging trends that are related to behavioral health. We also identify and monitor statewide behavioral health priorities and then look for some of the key trends and emerging trends that needs more attention from a research evaluation perspective. We also, our findings usually help legislators, prevention planners, and community organizations to make, as I said, the informed decision-making. And we try to use data-driven evidence-based approaches in some of these recommendations and research as well. So I know I see several of our committee members here. If you don't mind, do you mind, please stand and be recognized? SEOW committee members? Okay, don't feel shy. And we have a few more watching online as well. So, and kudos to this committee. The way we work is there's a lot of intensity in terms of interesting topics and sessions done through these kind of discussions. And we have, in fact, a lot of data coming from different state agencies. All of these folks are instrumental in providing us with that much needed information to give a holistic view of where Indiana is in terms of behavioral mental health. So just wanted to say thank you all for your time and support. So now the elephant is out of the bag. We all have heard from Doug and Jay in terms of the overdose death rates going down. Now let's take one step back and see, let's dissect the data, right? So I think on the left side, you see the national trends. This is coming from CDC's latest report. And what you're seeing here is something called a provisional count. Okay, so when I say provisional count, it's a predicted provisional count. So what that means is there are still a lot of deaths that has been investigated. So always when you take the actual death, it's underreported. So CDC already give you a predicted version of what that potential deaths could look like. And that's the data that you're seeing. So then it becomes easy for us to dissect what is going on. So on the left side, you see the national trends. And then as you see here between, let's pay attention to the last couple of years where December 22 to December 2023, that's the last data point available there. You see nationwide, there is a drop of about 3% down. So in December 2023, in nationwide, there were 107,000 deaths, or drug overdose related deaths. Now, if you take a picture to the right here, you see that sharp drop all the way from January to the December 2023, and that is where you're talking about 17.9% death changes in or decline in the death rates between December 2022 to 2023. Now, being an economist and seeing these data in a different levels, I would like to see to what year, what levels has we gone back. I mean, going down is great. So if you can see here, that's where the trend is going to help right there. Now we are back to October 2020 levels. So that's what I would like to see. Now, can we go back further? Absolutely, we can. But where are we right now? So right now, our baseline, what we are trying to see is we are comparing our current death rates to October 2020 levels. So that's a good sign. And we would like to see where things are going in the future too. Comparatively to the other states, again, this is coming from CDC again, this is just changes in the death rates between December 2022 to December 2023. As you can see, obviously, Nebraska had about 25% down in death rates, but next closest, the darker blue indicates the highest declines, right? So Indiana is one of them over there with 17.9% death rates as well. So you now see comparatively to other states, where are we here in terms of the decline? Let's go one more step in detail. Okay, we talked about the overall deaths. Now let's look into specific deaths from the perspective of what type of drug class. So no surprises here. So there are different color coded here. So the black one is the overall drug overdose deaths, which was in December 2023, 2,190 deaths. Now, what I would like you to see from here is let's look at the distribution of the class as well. And again, all these categories listed here are not mutually exclusive. There is polysubstance use involved as well. So, but at least it will give you a picture of what are the top drugs here. So the line below the black one, no surprises there. It's synthetic opioids. Synthetic opioids in the sense it includes drugs such as fentanyl and tramadol, but it does exclude methadone here. So those are contributing to the highest number of deaths there. The bottom one, the gray one, is all about psychostimulants with abuse potential. This is like drugs such as methamphetamine. The pink one that you see here is the next one, which is cocaine. Now, if I see that, I would be cautious looking into, I don't see a decline in the trends. The rest of the graphs, I see at least some sort of decline happening, but in cocaine, I don't see that decline yet. So that's something, let's take a look at it next year and see where we are on those as well. So just wanted to kind of point that out. But if you see the other trends, it's going down. The green one there is basically natural and semi-synthetic opioids. That includes drugs such as oxycodone, hydrocodone, and morphine as well. So that is going down. And the last two, heroin and methadone deaths too. So you see these differences in the drug class right there. Now, again, the data where we have is from Jan to the more recent December 2023 data. Now, what I also tried to capture this data to see, okay, are there any differences in distribution when compared to the nation? The same distribution there. I mean, I don't see any differences in concern. The orange one is for the nation, Indiana one is for the blue. The distribution in terms of number of deaths contributed by each drug class is pretty similar. It's, I would say it's not statistically different from the nation. So no big finding is a good finding too. So I just wanted to kind of let you know that too. So now that we have spoken about the big picture here, now let's look at other drugs here. So what is SEOW focusing on? SEOW focuses on these many drugs, substance use, and also behavioral mental health aspect as well. So just to give you a perspective, we have close to 95 measures that we use, a combination of data coming from federal sources, state sources, and also from local sources as well. So we compile all of them and then pool them together for each of these drug classification. And we break them down into prevalence and consequences and whatever spillover effects that we can find, so that we have a holistic picture for each drug, so that you can look into the, the concentrated efforts from prevention, treatment, recovery, and others. So in the interest of time, again, if I keep going for each and every measure, so we have to skip lunch, right? Which is not a good thing. So I'm going to give you, and the slides, all, by the way, will be posted in our website too, so you don't have to take notes, but listen in what I have to say, digest whatever I can, and the recording is also available after the meeting too. So I'm going to specifically talk about certain measures and metrics that we will actually leverage, but I'll give you a bigger picture of what to expect from each of these key points. So let's start with alcohol here. So in 2022, we use National Survey of Drug Use and Health as a measure of the usage of alcohol. And the current alcohol usage is reported as 46.5%. Users have reported drinking alcohol. The national average is 48%. So when you are dissecting the data into different age groups, young adults, 50% of young adults have reportedly using alcohol in the past month. This is current alcohol use. And we can see the data. If you are looking into like some of these numbers, I put some arrows here. So some of these are not statistically significant too, but I just wanted to show you in comparison to the previous year. You can see whether it's a big jump or a small jump. You can see that from there, that particular small arrow going up or down over there. But the point here is when you talk about the vulnerable risky population, I would say like 18 to 25, that number is pretty high, 50% of them. At the same time, when you're talking about binge drinking, about 21% of users reported binge drinking. And if you see the graph on the right side here, so that's comparing the Indiana versus US data on binge drinking by age group. Again, that 18 to 25, that age group is the highest in terms of binge drinking. Again, we are relatively closer to the nation, 29.2 versus 29.7. And again, across all the other age groups, it's similar to the national average there. So we then use different data sets. So that is coming from National Survey of Drug Use and Health, which uses data from 12 plus years over. And then we have used CDC's BRFAS data as well. In CDC's BRFAS data, it's only adults 18 plus. We leverage that information as well. And then there you can find that about 50.7% of adults have used alcohol. But if you now split them in by gender, 55% of men and 45% of women used alcohol in the past month. And if you want to pay close attention to the women's use of alcohol, it is 44.5%. I just wanted to recall for those of you who were there last year, the year before, during the pandemic time, the data during the pandemic time, we saw increases in percentages of alcohol use among women that was going up. And we expected that to go back to that pre-pandemic levels, and which is actually going on the right side there. So I just wanted to point that out while we are looking at the data. And then when you're talking about alcohol use disorder, about 10% of those population reported having alcohol disorder in the past. So again, going back to Armin's your talk on the TEDS data, right? So we also leverage TEDS data. One of the good thing we have is that's the latest data we can ever get directly from the state, because even though national level, it is still 2021. Now we are talking about state fiscal year 2023 data that we can leverage. So we are able to get the most recent available data from DMHA that we are able to leverage. And I wanted to take a look at how these substances are classified. In fact, actually, these are like top 6 substances there who are seeking treatment in any facilities here in Indiana. And as Armin mentioned, there are several data sets that, there are variables that says, what is your primary use of that particular drug? That is, we call that as the substance use dependence. And then you have either primary or secondary or tertiary will be the use. So that's how we kind of classify them. And that's where you see this particular data set here. If you take the second tab or second graph or the bar chart out there, alcohol, you can see close to 30% of your admissions. There are about 22,000 admissions in state fiscal year 2023. Out of them, 30% of them are relevant to alcohol dependence. So it's a pretty sizable number there. But they also reported 44% of them reported either consuming alcohol as a primary, secondary, or tertiary use. So that's one of the major things that I would like to take away from here. And you can see other drugs as well, like the marijuana, meth, heroin, opioids, and cocaine. I wanted to pay close attention to marijuana there, and I'll come back to that when I talk about marijuana slide there. What marijuana shows there is the higher number of substance use, but the dependence, which is why I'm seeking treatment for, is pretty small. Keep that point in mind. I'll come back to this particular point when I'm talking about marijuana. consequences. So as a result of these alcohol mortality, obviously alcohol or attributable mortality is one of the key aspects of where are we in terms of alcohol-induced drug mortality. And you can see those numbers on the right side where we are comparing Indiana data with the US data. This is something we might probably have to check one more year next year. Maybe, I don't know whether it's statistically different from Indiana versus US, but I do see a small gap. The orange line again is for US. Indiana is still steady out there in 15.1, whereas US is 13.5. There is an overall decline in the nation, but we need to see one more year of data, whether it's a statistical break there between the nation and the US. So the remaining things, as you see, collision rates, child rumors, there is not much of a trend change there. I think it is still similar to what we have seen in the past year. So again, key takeaways, the alcohol use has been declining. Binge drink among young adults is now compared to the national average. Last year, it was higher than the national average. And the alcohol-induced mortality slightly has increased. Let's switch our gears to tobacco. So about 24% of users reported current tobacco use, and this is coming from NSTUH survey, and cigarettes, it's 19.7%. So overall, that number is dropping down, but we are still higher compared to the nation. For any tobacco use in the past month, for the entire nation, it's only 19.1%, and we are at 23.6%. For any cigarette use in the past month, the nation, it was 15.3%, and we are at 19.7%, but still the trends are going down. Still, there should be some more work that needs to be done to close that particular gap. And you can see if you are taking the data, parse it down by gender, 17% men and 15% women smoked in the past year. And then we also have data among youth, right? Cigarette use or tobacco use among youth. The good sign here, I wanted to point out here, based on the 2022 data from Indiana Youth Tobacco Survey, from 2018, that on the top line is on high school students, and the blue one is for middle school students. Only 23% of them back in 2018 reported using any tobacco products. And fast forward to 2022, that number has gone down to 10.5. Same thing for middle schoolers as well. When it comes to the e-cigarettes, so you can see using the same survey, that number dropped from 18.5% to 9.2% in 2022. Now, this is for high schoolers. There could be several things that is going on behind the scenes. Either it could be because of the minimum legal age for smoking got increased from 18 to 21. That could be contributing to these declines. Device taxes on e-cigarettes was implemented as well. That is, again, going back to economics. When you have a cost involved, you should see a demand going down as well. So that's about tobacco. But as an economist, you also need to see, is there any spillover effects, right? When there is restrictions on policies and all, you also will see changes to, say, retailers failing inspections. When I say retailers failing inspections, they knowingly or unknowingly giving tobacco products to the minors, right? So how many inspections are failing? So if you see on the left side, that was back in 2022, there were not much of, all of these are like violations that you see here. And then I tried to track back in 2023 and 2024. This is from DMHA's CNR system. You can see those bubbles are higher for both those years. That shows that still a lot of retailers are failing those inspections as well. So that's something kind of to take a note of, because it also have got a spillover effects on the illicit use of tobacco. Again, key takeaways: smoking rates have declined drastically. Still, we are above the nation, and e-cigarettes and cigarette use have gone down among youth as well. Let's switch gears to marijuana. About 12% of them reported current marijuana use. And when you're talking about this data in terms of different age groups, as you always see, 18 to 25, about 25% of them are actually using marijuana. And then you have the next highest is going to be 26 and older. And if you recall my earlier comment that I made,
people who were using marijuana, they were pretty high in that treatment episode data sets, if you recall. But if I'm seeking treatment for that particular addiction, they were only pretty smaller. So what does that mean? Think for a minute. Again, what I'm trying to say here is, if my primary substance is going to be meth or cocaine or heroin and I'm seeking treatment, I'm also consuming marijuana as well. So is marijuana an instigator for me to try other substances, making other risky behaviors? I have no idea. That's something that we need to kind of investigate on to see what is driving our behavior to try different products. This could be one of the starting point where we can just look into the research perspective as well. So I just wanted to bring that point up here. The key takeaways, because of our neighboring states, Illinois, Ohio, Michigan, they all have legalized recreational marijuana. Now you would see probably an impact, consequences going on in maybe a spillover effects going on, either bringing them back to the states, maybe in border counties. I don't know whether it will have an impact on traffic violations, high speeding, and other aspects as well. So this is something that future research will tell us. Let's go to opioids. So when it comes to opioids, obviously, as Orman mentioned about prescription rates, so that is something that we also take a look into. So based on the latest data, it's 177 prescription dispensation rates per 1,000 population there, a slight decline from previous last year at the same time, the quarter. But again, nothing meaningful. At least that data is pretty much stationary, that prescription data. But at the same time, NSTUH gives you some idea in terms of how the prescription misuse is also happening as well in terms of prescription pain relievers. That's how they code. So 1 in 50 users reported misusing prescription pain relievers. And one of the other aspects is going to be going back to the treatment admissions we talked about. So about 16.7% of treatment admissions reportedly using opioids, and this includes both the fentanyl use as well. And only 8% of them reported using opioid as a primary substance. Now, if you take a distribution of those entire 21,000 patients seeking treatment, only 8% of them are actually seeking treatment. Now, there may be a lot of work involved. Now, we heard from Jay, there is a lot of activity happening in terms of increasing the bed size and treatment facilities. So those data are yet to be realized because this is like 2-year lag in the data. Now let's talk about consequences. As I mentioned, we already spoke about the overdose death rates, but there is also other spillover effects as well. Now this is coming directly from Indiana Department of Health data. When we talk about per capita, so you can see about 40.8 deaths due to drug poisoning per 100,000 population. That's the measure that we can actually look into. That is going down, which is a good thing. And then if you're looking into anything involving opioids, that rate has also been going down, 31.9. But this does not include the 2023 data, which is preliminary estimate from CDC. But most importantly, I would like you to take one step back in terms of the resource utilization, right? So when I say opioid overdose deaths, let's take one step back in terms of the ED visits. Imagine we should see a similar decline in there too. And yes, we are seeing those decline there in ED visits. Right back in 2022, the visits were 6,729 ED visits due to any opioid overdose. And that's close to 1,400 visits lower. So which is a good sign. Now think about this, there is a spillover effect where you can actually attend to other emerging conditions coming in ER. So it's a cost savings that I would like to say, point that out. Again, as I mentioned, overdose deaths involving opioid has been declining. However, as Orman and others mentioned, lower drug prices is always going to be one of the hurdle there. Polysubstance use is another one, and xylazine, which is mixed with fentanyl, is going to continue to provide a public health challenge for us. But at the same time, whatever decline has been happening, I think one of the key areas that we would like to investigate is, okay, what are the programs that are being effectively, what is working for Indiana, right? Is it prevention and harm reduction programs, overdose response projects, overdose and naloxone education, syringe service exchange programs? There are so many out there. So we would like to now tease out to see looking into what would be the contributing factors, that is something that we will leave it for the future research. To touch upon heroin, only a few percentage of population, 1% of population used heroin in the past year. But I wanted to point that out. So those who were using it, if you look at the TEDS data again, about 10% of the episodes mention they are using heroin as a primary substance. That's what they are seeking treatment for. At the same time, 17% of them used heroin use as a primary, secondary, or tertiary substance as well. I want to spend some time on cocaine here. So again, as you saw, the death rates of cocaine has not dropped down at all. So that's something that we need to kind of take a look into it. But if you take a look at the prevalence, only 1.4% of users used cocaine, and young adults, 2.8%, so close to 3% of young adults have been using cocaine. But when it comes to the treatment admissions, 11% of these admissions used cocaine as a primary, secondary, or tertiary device. So what it means is only 4% of those episodes who reported cocaine use had used cocaine as a primary substance. So again, I'm thinking this through. Think about these treatment. So people who are seeking treatment, I mean, maybe there could be room for more education on cocaine treatment. That could be something that is not effective. I don't know. So that is something that to be explored more so that we can now then see decline in the death rates for cocaine use as well. So I just wanted to point that out there. The last one I wanted to talk about here is on the meth. So on meth, we are talking about very few percentage of them using meth, 1.2% of users using it. However, if you see the treatment admissions data, 43% of them used meth as a primary, secondary, or tertiary substance. And 26% of them actually seeking treatment because of the meth use addiction. And as mentioned by Adam and Orman, the clandestine meth labs numbers have been dropped dramatically, with the number of arrests made has declined a lot. Again, the key point here is people who are seeking treatment are actually using meth. And again, just to summarize, I think that's maybe this is one of the contributor for the polysubstance use as well. Now let's move our gears now. So far I spoke about substance use, prevalence, consequences. Now let's take a look into mental health. So based on the latest data that is available with NSDUH, 1 in 4 users reported having any mental illness in this past year. About 6% of them reported serious mental illness. Those numbers have not changed much, not statistically different, which is good, hasn't gone up or down much. But at the same time, about 9% of them did report having one major depressive episode. So now if you take a look at on the right side, where are we compared to the nation? You can see the blue line the blue bar represents Indiana data. And then the orange one represents the US data for any mental illness. That numbers, especially among the overall and 18 to 25, is higher than the nation. So comparatively speaking, based on the methodology used by NSDUH, we are still higher in compared to the nation on those particular front, on that as well as on the serious mental illness. So why does it matter? This is the latest available data that we have from YRBSs on suicide attempts in youth. And as you can see, after 2015, due to lack of sample size, we did not have any data. But fast forward to 2021, we have that data right there, which is 11.8% there. I wanted to give you a perspective, where are we compared to the nation too, right? So back in 2015, when Indiana rates were 9.9%, so US rate was only 8.6%. That was back in 2015. Now fast forward to 2021, when we are 11.8% here, US rate is only 10.8%, sorry, 10.2%. So there is a 1.6 percentage point gap between us and the nation. So that's a huge difference that we are seeing. So suicide attempts continues to be a public policy issue. This is among young adults using a different data set on National Survey of Drug Use and Health. About 3% of young adults have reported attempting suicide in the past year. I showed this particular graphic in the last year. So why we need to kind of dig deeper into these issues, or why is it that what are the steps we can take as practitioners, as policymakers, or as researchers, right? So this is one of the a graphic where we talk about. I know it's pretty small. Apologies for that. This is coming from the Indiana Youth Tobacco Survey. I just want to point out the statistics where they say 36% of students felt sad or hopeless for 2+ weeks in the past year. Now, why is this measure important? Because this is one of the precursors for suicidal ideation. So that number is staggeringly going high. And again, this is just a trend across Indiana schools. Not all of them are being reporting, but on an average, you can see the trend going up there. And that is predominantly high, for which gender? It's actually high for, any guess? Females. They're pretty high for females. 47% of them reported saying they felt sad or hopeless, compared to male of 24%. That's the huge staggering difference that we are talking about. Now, why is that statistic important? I'll give you one other example here. Here is an example of cyberbullying. This is coming from Pew Research Center. This particular survey is back in 2022. Nearly half of US teens have reported being cyberbullied. So the survey technically asks teens whether they have experienced these 6 types of cyberbullying on the left side, and about 46% of them said they have encountered at least one of these behaviors, and about 28% of them reported experienced multiple types. Now, if you scroll on the right side, you can see the distribution there too. Again, girls have got higher distribution than boys on these particular cyberbullying behaviors too. Again, this is just one factor here, right? I want to show you one study that actually talks about the relationship between bullying and suicidal ideation. So you can see how bullying has an impact directly on suicidal ideation, but also through sadness and sleep as well. So sadness, as I said, sadness, hopelessness, all of these are the mediating link between bullying and suicide. So what that means is there are several risk factors such as depression, low self-esteem, anxiety, loneliness. All of these contributes to a factor for suicidal ideation as well. So I just wanted to give you that connection where how everything could be tied to each other. But again, this is just one of the many factors there. Now let's go back to the consequences on heterogeneity. As I said, 15% of men and 30% of women reportedly being told that they had depression. Again, that numbers have been going down. Back during the time of pandemic, those numbers were exorbitantly high. At least the trend wise, it is going down. There is also a differential rate of differences by race as well, as you see there. Consequences wise, if you see age adjusted mortality rates by suicide, that number, Indiana number, is actually, the gap is increasing there. So back in 2021, we are talking about 16.4, the mortality rate being 16.4 versus US rate is 14.1. So just wanted to point that out. So again, good news is depression rates for women has been going down in general because it was pretty higher at that time during the pandemic. Mortality rates continue to be higher than the nation here. So last year, we spoke about older adults. I got a comment at that time whether do you have statistics about older adults, how their behavioral mental health symptoms are? We gave it a thought. So here's why older adults are going to be crucial here, because a third of adults over age 45 experience loneliness, and only a quarter of those aged 65 and older are viewed as socially isolated. So those are two different things. So older adults face a higher risk of both loneliness and social isolation because of the factors such as living alone, loss of family or friends, chronic illness, and hearing loss too. So we decided, okay, SAMHSA recently released a report just focused on older adults using the National Survey of Drug Use and Health. And this is a national report, national data as well. But I would like you to think through, these are vulnerable population, 60+-year-olds. And we want to see if there are any differences in many of these behavioral mental health conditions. And what could that be? Is there any variation across gender as well? So without further ado, on the left side, you see alcohol use. Just big picture, 13% of older adults reportedly using binge alcohol use. And then there is a heavy alcohol use. Out of them, 3% of them were using heavy alcohol use. So heavy alcohol use, basically binge drinking for 5 or more days in the past 30 days. That's how they use that particular measure. And there is heavy differences between male and female. Among male, it's 15.5 versus 10.5 for females. For cigarette smoking, again, the US rate overall, irrespective of whatever age group it is, for alcohol use, it was like 21.7. But when it comes to cigarette smoking, overall US rate was 15.3%. But among older adults, you can see 12.4% is what you see for that particular age group, and then 11.3 for female and 13.7 for male. So just fast forward a couple more other things on illicit drug use, the same trend. Older males continuously have a higher levels of illicit drug use. That's the first one on the left. And then marijuana use is pretty high there too. And opioid misuse is pretty much similar in statistical terms. On the right side, it also tells us the modes of marijuana use as well. So apparently, and it's pretty small there, but so about 73% of male reported using marijuana or smoked marijuana, compared to 58% of them who use marijuana. Interestingly, for females, 41% of them ate or drank marijuana products, and then 34% of them for male. And then you can see the distribution going down in that particular front as well. Couple of points on mental illness and major depressive episodes. Interestingly, when it comes to behavioral and the substance use, you saw more men. Now, when it comes to mental health, you can see more women compared to men reporting any mental illness or serious mental illness compared to men among that particular population. When it comes to the major depressive episode, this trend continues. Females experience more than male here too. So just wanted to give you a perspective. I mean, not all the demographic has got the same data there. It does differ across different age groups. This is kind of like an evidence to show that. So as a result of SEOW work that we have done, we have last year we partnered with HITA team. So one of the key things I want to point out is you may probably see all of these data points coming in. I'm talking, we are right now in 2024. We are still talking about 2022 data. Right? I think there's always a gap of 1 or 2 years, right? So we are trying our best to figure out, okay, how can we know whatever data is available that is up to you for you to make decisions in terms of prevention efforts or education efforts or whatever efforts needs to be done. We need more recent data. And that is where we partner with HITA team because they use qualitative data. They send out a threat assessment surveys across the state where law enforcement officers, they put in their information about what type of drugs, whether they're seeing an increase or decrease in availability or demand or price and other information too. So we are going to leverage that data. Thanks for that partnership. And then we are going to put them for public domain so that you will know based on the latest threat assessment results, where are we on these kind of availability. So, and this is available in our SEOW website. And from there, you are able to do an interactive data sets that you can actually see. I mean, these are just some screenshots coming from there, like what drug poses the greatest threat in your jurisdictions. Overall, it looks like fentanyl is 51% of respondents said fentanyl. So at least you will get to know what trends are going on. And the hope is that here is another one where you can pick and choose the drugs and then see whether it remained the same or increased or decreased. So that way you can also provide your targeted resources accordingly too. And there are some qualitative work and analysis that's been done too. So feel free to use this particular website to your advantage to see how we can actually leverage. And one of the key things that we are currently working on is to add the county flavor to that. So this is at a state level. The wish is that we will go county, each county, how much ever the officials have put in their qualitative work on that particular front, you will then able to dissect locally what is happening, what type of information is going on. So that work is going on right now, and we'll continue to update this with the latest threat assessment results data as well. So I want to wrap up with a couple more slides talking about the behavioral health priorities. And these are specific priorities that we actually monitor every 5 years. And these are specific goals. The committee chose, okay, let's go ahead and see where are we on some of these measures and metrics. And then is there anything else that needs to be done from a policy recommendations or advanced analysis that needs to be done? We will take a stand based on those particular priorities as well. I just wanted to give you like a very high level overview. Again, the slides are shared. Don't get into too details, but I'll give you the bigger picture here. The greens indicate there are improvements happening compared to the previous time period. The reds indicate there will be a slight increase or it may be similar compared to the previous period, but nothing concerning. Everything we are going on the right track on alcohol, relevant measures for the priorities, drinking, tobacco use, even the opioid overdose as well, it's going down. Except for the suicidal side of things, the mental health side, it continues to be a challenge. That's something that we want to kind of look into it more carefully from a suicidal side of things. And then we are going to explore some overdoses involving xylazine mixed with fentanyl. Like we are going to explore some of those research going on. Recreational use of marijuana in Indiana from neighboring states, that spillover impact. We are going to explore that as part of the work group initiatives. And also we are going to talk about specific data collection efforts on vulnerable population and also monitoring cyberbullying trends. So just a couple more updates on, we will be releasing some special topic reports specific to community addiction service assessment. So we have one session coming up later this afternoon. My colleague will be talking specifically about community addiction. So what initiative we are kind of taking from there. And we'll be updating our annual reports and putting them in our website by end of next month in June. And then we'll continue to work with HITA team on providing with the more recent data in there too. So I will leave the rest of probably 15 minutes for any Q&A that you may have. I know it was lots thrown at you, but I wanted to take this time to answer any questions you may have, any research topics you feel the SEOW should be concentrating on for the next fiscal year while we are looking for topics, but let this be more informal. Yeah. Right. So the way we have structured here is looking at drug use is one of them. Like even in drug use, we want to kind of look it up into say alcohol through all of these different types of drugs because we cannot lump everything into one single drug. So that's one of the main reasons why we wanted to kind of look at it at a drug perspective. But when it comes to the trends, as you see, at least we are heading down the trend, but if you look at nationwide, even nationwide is also going down. So what I'm trying to point there out in wherever I can is the gap widening or narrowing down? That's the difference. Whatever Indiana is going to make, if tobacco use is a classic example, where the trend, Indiana's trends are going down, fantastic. So are we even closing the gap compared to the nation? Because back 10 years back, it was so wide, but at least we are trying to close that particular gap. So that's from the drug perspective. Again, from mental health, I know it's one of the serious challenges that we continue to face from different perspective. When I say mental health, it might be suicide related. It could be correlated with drugs as well because of chronic conditions. It could be co-occurrence of conditions as well. So we need to kind of dissect them in a different way. And that is what we are trying to attempt here, looking at your current measure relevant to the nation, but also is the trend closing as well. Does that answer your question? Yeah, absolutely. I think that polysubstance use is one of the key things that we want to kind of leverage on. So what I don't have it in the slide is we use TEDS data. I think that's one of the areas where we use it primary, secondary, tertiary, but we also would need to connect that with if it is death-related ones, these are treatment-related ones, but when it comes to the death toxicology reports, it will be one of the other aspects we need to figure out, but we still won't be able to know what was the initial, use. I mean, are they using it both unknowingly or knowingly? Those are some of the things we may not be able to tease out, but at least we can make that attempt to figure out that differences. Yeah, thank you. That's a great point. So one of the key things is we don't know the THC levels of marijuana that's been used, right? So the higher the THC, then you have issues with then you're talking about other aspects as well. And then what forms of marijuana has been consumed. I know that's something that we want to leave it for future research. But having said that, the way we have leveraged the data is whether or not have you used marijuana in the past year, or along with what other substances do you consume? I think those are some of the classic questions that will be asked during the time of admissions when it comes to the TEDS data, right? So that's one part of the story in terms of the usage of them. Now, that usage can vary. We don't know how many of them are addictive users versus recreational users versus what forms, and that the data that I showed you for older adults, we don't have that yet for the Indiana data. So now if we are able to get that combined with the other forms of drugs, I think that'll be a classic way we can see which one is correlated to what, because there is no causal angle here too. We cannot say which is making people consume more of a certain drug. We cannot say that for certain. It's only the co-occurrence is what we can predict. But combined with other factors, such as we can speculate by hypothesis saying that, okay, maybe this drug is available because it's of low cost, and that is actually contributing to this particular increases in use. I know those kind of hypotheses we can make, but nothing in terms of determination that we can make in terms of what proportion will be happening. Yeah, I think that's something that we will continue to look into from the border counties from Indiana. Are we seeing also similar kind of effects there too? Right, I think then you have something to differentiate from there. I mean, if there is evidence going up or down. And then one comment before I get to you. So there is also a work done by Criminal Justice Institute. They have something called Sotexo. I don't know whether people are familiar here. So it's like a device, a mobile device, drug testing device that I think there are 200 of them there. So if people driving erratically, or if there is evidence for the law enforcement agencies to stop them, they can actually use the oral vibe to test it out for, I think, close to 8 different types. One of them is THC level. So again, we'll be working with CJI to see if we see any evidence of an increase in THC levels across these border counties. That could be a way to proxy for some of these additional direct influence on some of these use as well. You had a question? Yeah, I think there'll be an ongoing effort, because now we have to look into the discharge data, or even if it is ER data, or maybe I'm talking about all this consequence data that we talk about. Those are some of the things we want to kind of leverage. But again, it becomes little, it's pretty hard to get use data, because it's because of the sample size issues and other things we want to kind of leverage. But one of the other aspects could be from TEDS data. We can also look into those treatment centers in that counters where we can see evidence of whether or not there are higher incidences going on there. That could be a direct in a measure that we can actually have a close proxy, I would say. Yes. Okay. Any other final questions? I'll take one more. Yeah, 2 more. Yes. I think I'll take my first hand, then I'll let Dawn hand it over to you. So one of the key things that we have been hearing is people may not know whether that's been mixed. That's one of the key predictors, I would say, because no one intentionally wants to die. Let me be very blunt here, right? So because they all know fentanyl is one of the key causes, but there is something that's been mixed. So maybe unknowingly people are consuming it. That could be one way. Now, is it coming at a street level, or is it coming at a distribution level? I know that maybe I'll leave it to Dawn to answer that. No, he's going to be the next speaker, so hold on to that question. Yes. Yeah. So I think that's our next goal, is to see, I know there are several agencies doing different types of programs, prevention, recovery, treatment. It could be, education, other aspects as well. So harm reduction programs, even in that, there are several of them classified. So right now, if we want to do a rich best study out there, probably let's take Indiana, for instance. We have a study design in mind. That's something that we want to kind of leverage, because all of these are introduced in an intermittent level. That doesn't mean that all counties went in and then did something then magically all of these things happen, right? So it was a progression that has happened over time. So that allows for researchers like me is like, oh, I allow that intent of the treatment that is different, that allows me to know which one is actually being effective, which type of programs are being effective. That will be a pure academic research that we would like to pursue. And I think that's something that we will continue to discuss internally within the group, is like, maybe can that concentrated efforts be figured out? And again, this becomes a little muddier because it becomes collinear. Maybe one program combined with another one is what maybe helping us go with the kind of a decline story, right? So I think like 988 rollout happened at the same time. There was naloxone distribution outlets happening, syringe exchange programs. We talk about the prevention efforts that have been overtaken, and all of these again back in 2023. So I would say it's a culmination at this point, but we need to figure out what exactly is causing the biggest return in terms of reduced deaths. I think that will be an academic research. Thanks, Dane. Okay, so I don't want to be a blocker between you and the lunch. So lunch is served right across, and courtesy sponsored by Syra Health. And they have a booth over there. Feel free to stop by their booth. And when you come back, I would like you to take a QR code here and then probably do a survey in terms of how we can improve the community. So again, from a SEOW standpoint, again, thank you all.
It's officially 1 o'clock, so I will go ahead and start off the afternoon session. Hopefully everybody is fully fed and ready to enjoy this afternoon's guest speakers. Next, we have 2 guest speakers for this upcoming presentation, Dr. Don McKay and Adam McFatridge. Dr. Don McKay earned a PhD from Purdue University and has dedicated 27 years to the Indiana State Police, with 25 years of state police investigator in various capacities. Throughout his career, he has served as a district detective, investigative squad sergeant, and squad sergeant for the methamphetamine suppression section. He has processed over 300 clandestine laboratory scenes and held the positions of District Investigations Commander at the Bremen Post and North Operation Commander for the Drug Enforcement Section. In March of 2022, he joined the Indiana HITA, continuing his extensive work in law enforcement and drug enforcement operations. Joining him will be Adam McFatridge. Adam graduated from Valparaiso University and has served with the Indiana National Guard for 27 years. For the past 17 years, Adam has been a criminal analyst with the Indiana HITA, where responsibilities include writing and editing the annual threat assessment, as well as writing and disseminating strategic products. Additionally, he conducts officer debriefings, provides tactical case support. With 18 years of experience as a human intelligence collector, Adam has conducted interrogations and source operations and provided management support to various operations. Please welcome Dr. McKay and Adam McFatridge. Thank you.
Lunch must have been good, still after it. Hi, I'm Don, Adam. We're going to move like, sorry, could have all died. Should be able to, hopefully we can go here. Well, there we go. We got an egghead title, so we sound real good. On the next slide. So this is going to be a phenomenological exploration of Indiana narcotics investigators' perceptions of challenges related to illicit drug problems. In other words, what do the coppers think? What do we think is coming down the line? And we're going to make some predictions. We're going to ask more questions and probably that we're going to answer. And we're going to go back and forth and be pretty loose and casual. Real quick, as Adam is running through, I'll tell you what HIDA is if you haven't heard of it. It's high intensity drug trafficking area. It's a program part through ONDCP. We are a program, not an agency. And our purpose in life is to help those areas with intense drug problems. And our goals are to improve the efficiency of HIDA initiatives and combat drug trafficking organizations and money laundering organizations. And that's what we're about. Every state is part of a HIDA. There are 33 total HIDAs in the country, as well as all territories also are part of HIDAs. And that's it. I think we're ready to go. Flip them. We're here for you. We'll go off script. You ask us anything. Our lives are open books. So unless Shrikant tells us we can't, we'll do whatever you want for the next 20, 30 minutes or whatever they're going to give us. You've heard some great presentations today. I mean, it's just been incredible. They're all going to seem better here in a few more minutes. Let's be honest. But feel free to jump in at any time. And with that, I think, yeah, we did that. We did that. We did all that. We did all that. We'll back up one, I think. So every year, one thing we have to do is we have to create a threat assessment to keep Washington, D.C. happy. It's mandated that all 33 HIDAs do that. Adam's the big toe on that project. He does a lot of the primary writing. How we go about it, we have a formalized survey. Thanks to Shrikant, I think Dane was here. They helped us rework it last year. This year we added a larger interview component where we're going out and talking with investigators, trying to draw as much information out as we can about what they think and what they're seeing. It wasn't too loosey-goosey. I mean, we had formalized training, formalized question plan. We did our coding through natural bucketing by the way we structured the questioning plan. If anyone wants to get into our methodology, we can do that offline. And we're going to tweak it again next year. We did that. Those are our counties. So, one of the biggest things that we want to know is what do the investigators think is the biggest drug problem? Well, there you go. And here's how we figured out. Now, we got a lot of statisticians in here, so if you want to say this is the stupidest way to do it in the world, well, that's fine. You can tell us that, and maybe we'll do it different next year. We did weighted averages. You ranked 1, 2, 3. We weighted them out, and this is what we came up with. So, Pradaline says that everybody's concerned about fentanyl and meth. Pretty hard and heavy. We'll talk about heroin in a minute, and we'll jump in on marijuana also just a little bit. Maybe. That's going to depend on you. But that's the 3 worst threats according to the people that responded to our survey. I think now it's their turn to. So, we can do one of 2 things. By a quick show of hands, we can go pure qualitative and talk about stories and quotes and what you all think they mean. Or we can show you charts and graphs and stuff. So, stories. I think stories got it. All right, so we're going to do stories. Stories. So I apologize. I have a thing for alliteration, so if you don't like it, it's corny, so am I. So we're not going to read to you because we can't read very well, and I sometimes move my lips anyway. Look at that, and then we'll ask the question. First question I ask is, how many of you think that police don't care about anything but the laws they're enforcing? I bet some of you probably have that. But I think if you take a look at this first quote, when they're trying to determine why or what the worst fentanyl, or that fentanyl is the worst problem, it comes right to the top because everybody knows that's what kills people. Any thoughts? What do you think? Next one? Adam, do you have anything on that one?
No, I mean, that's the big story with fentanyl is it's everywhere. It's mixed into every drug. I know that was talked a little bit earlier. We'll get to the chart, but you'll see every other drug overdoses increase that typically don't have a lot of overdoses. It's all because fentanyl's in there. Now we have a lot of naloxone all around Indiana. Every other drug, cocaine, meth overdoses are starting to go down a little bit along with the fentanyl overdoses. So it's mixed into everything. We've even seen the intent of dealers from an interview. It's the intent of dealers to put fentanyl in everything like cocaine, because now you have a customer for every few hours sometimes instead of just once a month coming back. So the way they view it is
not very ethical, but I'm going to put fentanyl in everything. I'm going to make a lot more money.
And we'll encourage you to think, yes, we're not taking away the health side of drug abuse, but put your thinking about economics hat through the whole time that we're talking. And then I think that'll come together. Pills are everywhere. Those of you in the treatment world, would you agree with that? Counterfeit pills fall from the sky. They're everywhere. They're getting cheap. They're getting cheaper and cheaper. As cheap as $1 a pill on the West Coast. $1 a pill on the West Coast. Damn, right? That's crazy. Now, the second part, though, is replacing meth and heroin. That's what this one cat says, that in his mind, that they're going to replace meth and heroin. We could talk our whole time on just this slide, but I'll ask you to do a little bit of drug crisis research in this country. And if you go back to the Civil War and start that, the opium crisis that happened after the Civil War and track forward in history, you're going to see that this country has cycled through problems. It's just this weird thing, I'll say the last 5-10 years or so, where we've had this dual opioid meth thing walking shoulder to shoulder. Are we going to break that? I don't know. Are we going to go? I don't know. But that's for you all to think about. That at least some people working drug cases are thinking that maybe this pill form of an opioid might be pushing other things out of the market. We'll get into a little bit more of that later.
One more thing on the counterfeit. He calls them counterfeit fentanyl pills just because they put fentanyl in everything again, but they're counterfeiting everything. So we had a case where it was ecstasy, or it was meth pills sold as ecstasy. A lot of cases we see where it's Adderall, illicit Adderall, illicit Xanax, Oxycontin, whatever it is, they're pressing fentanyl pills, whatever other garbage they put in it, and then whatever you want it to be, that's what they tell you it is. And they do it with all drugs. So you've got, obviously with heroin, we'll get to that a little bit, but if you ask for heroin, you're going to get heroin. Might be pure fentanyl, the synthetic version. They're just going to say it's heroin. Even black tar heroin, the worst quality heroin that you can get. If you order up black tar heroin, it's they're going to make it look like black tar heroin, but it's fentanyl. So they're just counterfeiting everything.
Lots of pills, lots of pills, lots of pills. Here's the thing, and here's an intelligence gap, and maybe you can help us fill it. It looks like pills have two distinct sources. You have locally pressed, locally when I say this side of the river, I don't mean the White River, I mean the Rio Grande, and stuff pressed cartel direct on the other side of the river. You look at seizures, CBP is knocking off heroin in very select sectors where they're ripping loads of heroin. Then you disperse out. So it looks like there are pills coming across already made, and there is powder coming across the border already made, and getting some of that powder is getting subsequently turned into various pills. Keep in mind, in this country, pretty much all fentanyl comes from Mexico. Very little out of China anymore, from what people can tell. Well, I heard somewhere that Canada is a fentanyl producer. Yes, they are. But I've seen no data that says Canadian fentanyl is coming south. They are consuming everything, or their fentanyl goes to Europe. And it is chemically different without getting into the synthesis. It's chemically different. So labs can tell, is it south of the border or north of the border heroin, or excuse me, fentanyl. And here's the thing. It's in everything. And we'll just leave fentanyl at that. We'll take a look at the death data that's been beat over your heads ad nauseum, but we're going to point a couple things out in our closing remarks. But just keep that in mind. It's everywhere.
So meth, I think the big story, same as fentanyl, they're both created in these super labs. Fentanyl is created to replace heroin. Cartels then don't have to deal with farmers, seasons, US blowing up their crops. They build it all, or they make it all in a lab, mass produce it. That's why you're seeing so much of it. Same thing with meth, it's made in the same labs. So they're pushing it. So fentanyl, they wanted to push it to replace heroin. Presumably, they want meth created in a lab to replace cocaine. So it's being pushed. It's flooded everywhere. It's where they're trying to create that market. Same way with fentanyl, where you put it in everything, get them addicted. They're trying to create that market by flooding it. Price is way down.
Y'all been to Costco or Sam's Club? Free samples work, right? In college, my roommate was the Skoll representative for Purdue University as an undergrad. And because of him and the cases and cases of free product that he was given, I was a loyal United States Tobacco customer for 20 plus years. Absolutely free samples work. They know that. We can get into more of that maybe later, depending on our time and our questions. Indiana, you saw some data already. If you go outside, you could very well be hit with a pound of methamphetamine just falling out of the sky in Indiana. It's everywhere. It is everywhere, and it's cheap. How much was meth, say, in, I don't know, 2015, 2014? Anybody know? What a pound of meth can run you? Y'all are too young. 14 grand-ish, maybe higher, depending on your taxes and stuff. Well, taxes is a term used in the drug trade about who it's going to and what organization they are going to get taxed. Now, what's meth worth? Anybody know? What's a pound of meth worth in Indiana? Read our threat assessment. It'll be in there because we went ahead and dumped out all the pricing data that we had too. But what's meth worth a pound in Indiana? How much? If there's a chance you could get as low as $1,000, you're right, depending on where you're buying. $1,000 a pound. All right. Dirt cheap. It's everywhere.
Cocaine is down to about 28,000 a kilo, down from like 32,000. So it still hasn't replaced it. Cocaine is still in abundance for some reason. I don't know if they're getting rid of their cocaine that's sitting on the shelves or what, but cocaine's still coming across the border.
And remember this, if you haven't cracked it, what's going to be the shelf life of powdered cocaine? It's a salt, right? So it's going to last, if I store it right, it's going to last forever. Well, forever is a long time, but you get my point. It's not like high-end weed that you got to keep moving in the supply chain. If I can stockpile it, I can stockpile it. It'll keep. Plenty of it. Is it working its way into the pills we've already talked about? You bet. You buy an Adderall tab because you're going to study for finals, and some poor college kid's going to buy an Adderall. They get an Adderall, a legit Adderall that's been diverted? Probably not. It's probably meth. And who knows what other unholy combination that's mixed into this crazy potpourri of whatever. All right. So the folks said heroin was the number 3 drug threat in Indiana. Anybody believe that? I see a couple heads nodding that, yeah, maybe it is. How about if I tweak it and say that heroin demand is a real drug threat? Think of those of you that are in the treatment world. Do any of your clients purposely going to seek fentanyl? Very seldom, if ever, right? So there's a demand for heroin, right? Think of it this way. You may well prefer Pepsi, But if all you can get is RC in a Pepsi can and it's hot, you'll probably drink it, right? And you'll convince yourself that it's going to get you where you want to be. So that is why in our heroin section, we talk about fentanyl, because it has basically pushed heroin away as an availability. And yes, it's more than just the crime. The average dope investigator, the average drug cop, they get it. They get it. It's a health problem. Now, do they spend all their time thinking that it's a health problem? No, but it's always in the back of their mind. And we throw this slide in there so that you hopefully at least get some sense of the fact that, yeah, we all have our job. The law enforcement, thinking of it as an economic problem, law enforcement is about the supply side. All y'all are about the demand side. We're trying to drive prices up by taking off enough supply. You are in essence trying to release the demand. We work together, we're going to get a lot farther if we understand what each other is about. Number 4 was Lucifer's lettuce. Technical term.
We put mushrooms and marijuana together when we did a threat assessment because a lot of the interviews came back. Officers were saying they're always seized together. Wherever we find marijuana, we find mushrooms, same users, same sources. So that's why we put them together. And it's kind of the same story once you start looking at it from that perspective that a lot of our surrounding states are starting to relax laws around hallucinogens, finding a lot of medical benefits to it, even with healthy individuals using it. So it's, and Don actually predicted last year that our seizures were going to go way up with hallucinogens or with mushrooms, and they skyrocketed. Now, officers don't pursue mushroom investigations. They're only looking for, for the most part, fentanyl and methamphetamine. They might take a cocaine case. They're not looking for mushrooms, but our seizures skyrocketed because they're coming across them.
Nobody looks for mushrooms. You're not going to walk into the boss and say, boss, I think I can go buy an ounce of mushrooms. He's going to tell you, or she's going to tell you, get your butt out the door and see what you can pick up on something else, anything but mushrooms. No one cares, but we're finding them. They seem to be everywhere. Violence is all around marijuana. That was a very common theme in our interviews. The violence associated with drugs in Indiana it seems to be most often associated with marijuana. And keep in mind, most of that violence probably isn't reported, right? Only the deaths, because it's pretty hard to hide. You're generally not going to get away with hiding a body. So you're going to figure out. Marijuana is driving violence, drug-related violence in Indiana. And I'll tell you another side thing. Purely anecdotal, I realize, but of all the drug stuff I've worked on, I can tell you one thing. I don't care if it is a meth dealer that's slinging a pound or slinging an ounce. Almost certainly, they will not have a pot to make water in, nor a window to throw it out of. All the money is with marijuana. Marijuana folks, marijuana dealers have the money. And they're young and they're stupid. And they post pictures on their social media of their guns and their money and their weed. And then Sam down the road says, hey, I'm going to I take what he has. That's just the nature of life. Sourcing for mushrooms, they seem to be moving together. I say seem, I don't know for sure. I don't think we can say that 100%, but they seem to be moving together in many cases. But mushrooms are going to be probably grown here as opposed to Canada or Mexico. So they're going to probably be domestically grown, and that's just the way it is. You've seen these numbers how many times now, but we're going to answer the question in our mind, what's going on. So, yay. But look, and if you want to know why things are moving as they are, we are convinced, and feel free to say that's the stupidest thing I ever heard. We're convinced the reason everything is moving together is because pretty much all dope in Indiana is dirty. Pretty much all dope in Indiana is dirty. Anybody want to argue that point right now? It's dirty, dirty, dirty. Fentanyl has hit everything. That's why they're moving together. What do you think? Am I right? It's dirty. You think you're buying cocaine. You're not. You're probably buying some cocaine with some fentanyl in it. You think you're buying meth, it may well have fentanyl in it. That's why things are going the way they are. Fentanyl isn't everywhere, it's in everything. We don't think heroin is the problem people think it is. We think heroin demand is the problem that's being filled by fentanyl. Nearly replaced heroin. You look at our seizures, we're not grabbing any heroin. No one's ripping heroin. They're ripping stuff that's being sold as heroin, but it's not actually heroin. And as I said, methamphetamine in Indiana is everywhere. So tell us where we're wrong. Tell us where we're wrong. Hallucinogens are going to be the next big thing. In our humble opinion, we already touched on it. One thing, if you get around to reading our threat assessment, one of our themes this year is that the street level dealers appear to be diversifying more and more, trying to become that one-stop shop. And we can get into why that is and whatnot. But instead of having a guy for marijuana and a guy for your crack, you're probably going to be able to more and more get them from one common source. And if I'm going to be carrying a broad market, I'm going to be carrying hallucinogens. Adam already talked about the fact that there's a lot of social interest in hallucinogens, a lot of research being done on hallucinogens, even more research being funded in this country coming forward. And here's the other thing. I missed it last year. I thought DMT labs in Indiana would come way up. They stayed about flat. Coincidentally, that's the last clandestine lab I processed before I retired from the department was a DMT lab. So they are around. DMT is terribly easy to make. Terribly easy to make. And you will almost never get caught doing it unless you get caught for something else. Because it's not going to smell, it's not that big a deal to do. And fire up the Google machine, or I can teach you in about a half hour. It's pretty simple. Anybody argue with this one? We think fentanyl is going to stay in everything, it's going to be in everything, for all the reasons that we've talked about. Think about the purpose of a drug cartel. They want to make money, and they know they make money by selling. And the best way to sell something is to get people either wanting to come back or have to come back. So if I put a little bit in with this and a little bit of fentanyl in with that, we have good interviews, some research saying that street level dealers are purposely tainting. We have interdicted shipments of cocaine being marked separately. So some of the bricks are coming in as cocaine and some are already pre-adulterated with fentanyl. It is purposeful. It's being done. We're almost out, so.
Okay, yeah, and I think this speaks to the availability of drugs, how much is out there, that you used to just have one pipeline for cocaine and you were a cocaine dealer. And now you can get your hands on everything. It's really easy to get, and you can be that one-stop shop so your customers can have whatever they want.
We think they're going to stay flat or maybe go down. And then click it quick because we got flashed. Here's the one we say cocaine's coming back. Cocaine's coming back. We acknowledge it doesn't make any sense, but the dope cops say they think it is. We've got We've got people that won't sell you your heroin in air quotes unless you buy a crack rock. People are starting to push cocaine. So for whatever reason, cocaine seems to be coming back. So there. How much time we'll take anything. We went longer than I thought we would. I apologize. Got about 4 minutes. What do you want to ask? Stupid stuff.
Yeah.
So way to triple bang on the questions. I like that. That's good style. So here's the thing. State Police Lab was not routinely testing for xylazine unless requested until the fourth quarter of this year, I believe. So I'll have a straighter answer for you next year when we take a look at what they're analyzing. Here's the thing with xylazine. Dirt cheap, not controlled. When I say dirt cheap, kilo for 20 bucks. Is it a real problem? Looks like it, particularly on the East Coast. Syringe recovery in Indianapolis area, Marion County says it's around. So yeah, it's real. Is it the next big thing, or is it a flash in the pan with some other new novel substance coming behind it? That's a good intelligence gap that I don't think anyone can answer with Euclidean clarity, as it were. But yeah, it's real. It's real. The reason it's such a big problem is it does not respond to naloxone. So, but no one's going to be taking xylazine. Seldom would anyone take xylazine straight. So if in this case of an overdose, you're always wanting to use your naloxone because that's your chance to hopefully knock off whatever opioids were in the sample that also had the xylazine. How'd I do? Get all three of them? All right. I'm here for you. No extra charge. Did that get? So Lucifer's lettuce questions. So here's the deal. Let's go to the big one. Now, I'm about to offer my opinion that does not necessarily represent anybody else living on the face of the earth or any organization anywhere. So making that clear. All I can tell you is that marijuana is legal in California and it's legal in Colorado, and they're still having violence driven by marijuana. So think about where the money is. And there, even states that have legal marijuana still have probably most of their users using illegally sourced marijuana. So just because the possession is legal doesn't mean it was sourced legally anyway. So that's something I don't think people always realize. You're not going to get rid of illegal marijuana by legalizing marijuana and having organized, governmentally controlled grows. You may knock some down, but you're not going to get rid of what is illegal because of price point, if nothing else. Although, what's the ounce price for weed in Michigan? Anybody know at the dispensary? Okay. No one is willing to tell us what they, no. About $100. So $100 an ounce for primo stuff is starting to get competitive to illicit sourced. So time will tell if the prices move enough because it's an economic problem.
Next, I'm happy to introduce another round of two keynote speakers, Sydney Whiteford and Connor McKinney from IU Prevention Insights. Sydney Whiteford is a public health expert with experience as a technical assistant provider, public health consultant, epidemiologist, behavioral health promotion. Sydney received her master's in public health from the University of British Columbia in Vancouver, Canada. She specializes in assessing community needs, data analysis, data visualization and utilization, health equity efforts, as well as outcome evaluation. She delivers culturally competent, comprehensive support that helps state and community level programs address system-wide issues, incorporate evidence-based practices, monitor progress, and support staff in achieving program goals. Sydney's recent TA experiences include serving as the internal TA strategist, addition to providing support to SUPTR, CRSA implementation and older adult grantees funded through the state of Indiana's Family and Social Services Administration Division of Mental Health and Addiction. She worked previously as a substance use prevention epidemiologist with the Indiana Department of Health, and as a prevention specialist with a local level HIV substance use prevention grant. Joining her will be Connor McKinney. Connor McKinney is an experienced technical assistant, provider, public health consultant, applied researcher, evaluator, and an expert in behavioral, social, and community health promotion. Connor received his master's in public health from the Indiana University in Bloomington. He specializes in assessing community needs, theory-based program design, strategic planning, mixed methods evaluation design, and implementation, data utilization, and grant writing. Connor's recent TA experiences include serving as a lead TA overseeing the older adults grant, in addition to providing support to SU, PTR, CCRSA implementation, and older adult grantees funded through the State of Indiana's Family and Social Services Administration Division of Mental Health and Addiction. Connor is dedicated to providing culturally competent, comprehensive support tailored to each individual community in order to build their own capacity to address local needs and to influence positive health outcomes. Please welcome Sydney and Connor.
Okay, good afternoon, everyone. As we were so warmly introduced, my name is Sydney Whiteford and my co-presenter is
Connor McKinney.
And we are technical assistant specialists with Prevention Insights at Indiana University. And today we're going to be covering unearthing data gold mines, navigating sources and strategies.
So something we like to do for any presentation that we'll give is start with a land acknowledgement. And so as you can see here, we would like to acknowledge that the land that we are gathered on today, now known as Indiana, is the traditional, ancestral, and unceded territories of the numerous indigenous peoples, including the Miami, the Potawatomi, the Piankashaw, the Wee, the Kickapoo, and the Shawnee people. We would also like to acknowledge that all of you are joining us from near and far, and we would like to recognize the traditional owners and caretakers of those lands as well. So today has been so far a great opportunity of looking at what the state of federal data is showing us on a lot of substance use problems and issues, as well as state data. But as Sydney alluded to, we are technical assistance providers, and we more so work on the community level, really helping communities around the state address local issues. And so through our presentation today, we're going to kind of take a step back and examine what we're seeing at the community level. And so really to get us started, we're going to take a look at broad categories of data that we're seeing being utilized by local coalitions around the state to really address those local issues.
And so when we're thinking about those data pieces, there are four main broad, as Connor said, categories. We see demographics, determinants, which includes those risk and protective factors, consequences, and outcome data. And so with each of these, we're going to break down kind of what the working definition tends to be for the sites that we're working with, as well as common examples of the types of data that they're pulling, as well as what their usual sources are. So we begin with demographic data. We know what that is, information about groups of people according to certain attributes. So we have age, sex, place of residence, your basic level data. The biggest one is always the US Census Bureau, which I'm sure is no surprise to anyone, but we do also see sites pulling data from the United Health Foundation's Americans Health Rankings, the IPRC regional data, as well as Data USA. And it's worth mentioning that these sources are not an exhaustive list of where all of our sites get data. However, these are just the most common places that they are getting data.
So the second broad category that we really see utilized are determinants data. And as you can see here, the determinants of health are what include the social and economic environment, the fiscal environment, and then a person's individual characteristics and behaviors. And so this can include the risk and protective factors, which influence how likely someone is to experience an adverse health outcome. And the one caveat we will provide here, and we'll provide a little bit more resources, is how you can solve this caveat later on in the presentation, is actually for the non-majority populations, determinant data is often a lot harder to find. And we see that around many communities, both rural, urban, and suburban. Some example points that you can find through determinants data, as you can see here, I won't read them all, but predominantly we're looking at like median income, access to health services, and those pro-social involvement opportunities. And then down below, again, the Census Bureau pops up, the Indiana Department of Health, and then the health rankings is, again, as some of the predominant sources that we're seeing our sites use to find this data.
The third most common type of data are consequences data. So again, this is the tertiary impact that the health issue has on the community at large, especially within a legal, clinical, and criminal justice setting. The common ones that we see are hospital discharge rates, school suspensions related to a health issue, mental health service use, arrests and citations. And the SEOW has actually been a great source that a lot of our sites use, especially the data dashboards. And again, you'll see some similar trends with common sources popping up again.
And then lastly, the final broad category will cover our outcome data. And so as you can see, health outcomes are the interrelated set of attributes that describe the impact of a health issue for an individual. Some example points that our sites are using as they're looking at outcome data would be the mental health diagnosis rates within their county or community, drug overdose deaths, and e-cigarette use, just to name a few that are up here. And again, some of the sources that they're going to define these, again, we have the SEOW reports dashboard, and then as well as the National Center for Drug Abuse Statistics. Those are the two predominant sources that we're seeing.
And so the final piece that we've gotten so many wonderful examples of today here at the symposium is the importance of comparative data when they're gathering all these different types of pieces. So we really try to impress upon sites, and what I think they have a really strong understanding of is that it's not enough just for them to pull data for their specific community. They also need to be able to find the same exact data points at a state and national level. This will provide more weight to the arguments that they're making that there is something different happening in their community, and this is able to quantify that. However, even though we instill within our sites and they understand that this comparative data is important, that doesn't mean it's easy for them to find. Usually state and national are a little bit easier for them to navigate. However, when it gets to that community level data, this is where they really struggle to be able to find these different pieces to bring this story together. And that is exactly what we're going to talk about next. What are the things that we, Connor and I, as their TA providers, as well as other people they're working with across the state, try to encourage them to do in order to solve these data gaps?
So as Sydney alluded to, oftentimes we know that it's more difficult to find specific data related to the issue that you're trying to address within your local community. Oftentimes our sites have no issue finding what the state level is or what the federal level is on an issue, given maybe like, let's say, past 30-day use of alcohol for those between the ages of 12 and 15. Oftentimes that's a lot easier to find at a national or a state level. But when you try and look in your community or you're just conducting an online search for local data, that's where we see a lot of the difficulties. And so what we will suggest to our communities is really utilizing some local quantitative and qualitative data to fill in those gaps and provide some more of that community context that they're looking for. And that's what we're going to focus on this part of our presentation. We're going to really start with some of the quantitative efforts that we see, because oftentimes this is where you'll want to start to get those raw local numbers, and then you can kind of supplement that with the quantitative, providing some of that perspective and community context afterwards. However, we'll start with surveys as the first quantitative method that we see used predominantly by our sites. And the neat thing about surveys is they can be both quantitative and qualitative. However, if you're focusing on the quantitative side first, as you can see here, is one thing to keep in mind is you really want to keep your questions closed-ended. So making sure that you're using scales, multiple choice options, or simply yes, no choices. And then, like I said, you can supplement these quantitative questions with more open-ended qualitative questions, either at a later point or even later on in that same survey. So predominantly, looking back at the broad categories that we've already discussed, our sites will use surveys primarily to look at demographics in their local area, determinants, and consequence data if they're trying to fill in some more of those gaps. And some of the primary locations that we see our surveys used, one that's really popped up here in the last few years and has really taken over our geofencing options. And we'll see that primarily at our next stops here we're geofencing around places where a large amount of the community will gather. So for our older adults, we'll see them geofencing at religious gathering spaces or assisted living centers. And for our families or for the younger youth that we're trying to survey, that's more so at like grocery stores, local parks, places where they're going to congregate. So the second quantitative data collection method that we'll see used by sites are observations, and specifically identifying the specific behaviors, services, events, or outcomes of focus, and then just documenting the number of times that those are observed. We'll talk more about qualitative observations in a few slides. But again, that is better to use to add context to the number of things that you're observing within your community or within the specific area of focus. And so predominantly we see our sites trying to use observations in this form to look for determinants or more so of those consequences that they're seeing within their community. So two examples that we see a lot are windshield or environmental tours and scans documenting, for example, the number of alcohol retailers in a community, or even documenting the number of grocery stores available per 1,000 people if you're trying to find out more about the social determinants of that area. So moving then into our qualitative options, what we really see our sites start with when they're looking at qualitative are these individual interviews, finding those community champions and just trying to get some information out of them that can really help to add that community context. And when you're looking at individual interviews, we have three major options to go with. So you can start with a structured interview if you're looking at that option. This is when the same amount of questions in the same order are asked of everybody. From a top-down view, this can seem like the most reliable form since you know that the interviewer is asking the same questions in every interview in the same order. However, this can often make the interviewee a little bit more nervous as this predominantly sets the interviewer above the interviewee, and there's kind of that dynamic struggle throughout the interview sometimes and can lead to them providing not necessarily false answers, but maybe not the full truth if they were more comfortable. The second option are semi-structured. So similar to the structured interview, the same base set of questions are provided. They just may not be asked in the same order. And this also allows for more follow-up that may not be asked in other interviews or in the same order at that. This does lead to a little bit more being sidetracked. However, this really starts to break down that differentiation between the interviewer and interviewee and moves a little bit closer to a more natural conversation, like we'll see with an unstructured interview. So with this, the interviewer is provided a list of questions that they could ask. However, they're not required to ask each of those questions. And there may be questions that are not on the list that get asked as follow-up that are not asked in other interviews. This is supposed to be more like a less formal interview and more like a natural conversation. However, from a top-down view, this one can seem to be the most or least reliable and most open to getting sidetracked. So as I said earlier, we have both quantitative and qualitative observations. And so the main difference we'll get into in a second that sets this apart from the qualitative. But as we're looking at quantitative observations, we have two specifics that we see a lot of our sites utilizing. Starting with direct observations, this is just about examining places, people, or activities without directly interfering or taking part in what's going on. And then on the other side, you have participant observations, where you're more involved in the actual learning, the taking part in a community's culture celebrations or everyday activities. The caveat we will give with this is that this is oftentimes conducted by a member of that community, a local champion, somebody that is very engaged just with the comfortability that's required and to be kind of welcome into a lot more of these intimate settings and cultural engagements. So as we're looking at what data we can collect through a qualitative observation, you're really looking more so at taking note on the physical characteristics of that setting, describing or providing a description of the people that are involved as opposed to the number of people involved, really taking a description of the activities, events, or places that you're observing, taking note of the nature of interactions that's happening there, and then also capturing people's apparent attitudes towards the place, the situation, or activity that you're observing. So again, the differentiation mostly is with quantitative observations, you're just counting the number of things that you see, the number of times you observe them. Whereas with the qualitative side, you can go more in depth as to what's happening around those numbers.
And I will say in terms of practical application for the sites that qualitative data collection methods are more frequently used when they're trying to target specific populations. And we're really trying to understand what a specific group of people needs. It tends to allow for more tailoring, more creation of a safe space so that more honest answers are shared.
So at this point, whether we're working with sites to either begin their data collection process or start their own development of tools in order to collect the data, they'll eventually get to a point where they have this just abundance of data and they really don't know then what to do with it at that point. And so a lot of the suggestions and work we do with our sites is to help them piece these bits of information together to really drive home that the decision-making should be informed by what the data is telling you. But at the same time, that's not where you should stop using your data. And so as Sydney will get into, we also have recommendations on how you can take that data, put it into bite-sized forms, and really spread it throughout your community.
This is a picture we often use when we're talking about this with our sites to appeal to people who are visual learners, I myself included. So we go with the Lego metaphor just to show them that you get to this point where you know all this data is out there, that very first giant unsorted pile of Legos. And then when you have a better understanding of the types of data that you're looking for, you can begin to put them in neatly sorted piles. And finally, as you have narrowed down, these are the specific pieces I'm interested in, you're able to start arranging it in a way that makes a little bit more sense. And where we've arrived now is working with the sites to teach them how to present it in a way that visually makes sense, as well as can be explained into a broader story which has more impact. And so what we really try to impress upon them is that it's worth it to take the time to refine all of this data that you have found. So we know, because you are the person who lives and works in the place that you're trying to do this work, that you have a strong understanding of what the problems are of your community. However, for someone who's never even stepped foot into your community, pulling in quantitative data like this can help assign numbers to the gaps that you see. And this can make an even more compelling case for why resources should be allocated to the place that you live and work. We also really try to encourage using data visualization beyond just putting it in future funding applications, but trying to work it into different parts of the work that you're doing, which we'll get into in a future slide. But overall, we really just want them to go beyond just having this pile of data and sitting on it, or only putting it in an application, because data is something that can be harnessed to showcase successes, challenges, and your continuing growth for capacity. And so one of the really big things we hit on is show and tell. So when our sites want to share data, we want to make sure that they aren't just making a graph or telling people what the data says. We really want them to use both. So we have some common examples that we show them. We have this graph here that we think is a good example, where not only are you trying to model how many of all drug overdose deaths can be attributed to opioids, but you're also telling them with just a brief sentence at the top. We want to make sure that data is easy to navigate, and we want to impress that upon the sites as well. We usually show them a subsequent example like this. It's a little bit more simplistic, but it's, again, putting some data visualizations to the point that you're trying to make. For the case of this example, that while opioid overdose is increasing for both males and females, males have a higher rate of opioid overdoses. And so we also really encourage them to share their story far and wide. We do not want them to limit all of this data that they're collecting, which we know is rich and very in-depth, to just future grant proposals. And so they've done things like work it into community newsletters, put it into social media posts. One event that we've seen sites have a lot of success with is Data and Donuts, or some food variation of that, where we get people in the door with a sweet treat, but then we use that time to come together as a community and talk about the data that we're finding. We also really encourage them to not data dump if they can't get people in the door or to listen to data, and instead, as Connor said, break it down into bite-sized pieces. A common example that we use for that is showing this data visualization from IU Health during the height of the COVID-19 pandemic. This is one piece of data. It's talking about the vaccination status of people who were hospitalized, but even with that one piece of data, you can tell a really rich story and in a compelling way.
So I know today has been a lot of looking at, again, what the federal data is showing us, what state data is showing us. And at times when you're starting your own search, looking for data can seem very daunting. And so really what we just want the takeaways today to be are, there are ways to sort out what you're looking for, and that data is ultimately your friend and not your enemy. Data-driven decision-making is also what's going to make the true impact that you're looking for within your community. And so once you've got that data, like we talked about with that picture on the Legos, is then sorting it into those groups, putting that story together, and using that to drive your focus, your vision, and your initiatives moving forward. And then lastly, just finding ways to work that data into your current work. Once you've got that grant application done or that evaluation report done, don't just set that data on the shelf. Find ways to include it in your messaging campaigns. Find ways to put it in pamphlets or flyers that get handed out at events or around town, just to better spread awareness around the initiatives that you're really trying to work towards.
And with that, we'd like to open it up to questions. I know some of the sites that we work with are in the audience today. If you have any examples too that you'd like to share about how you grew your own data in your own community, you can share that as well during this time. Thank you everyone for listening. One of the big things that we stress when they are collecting this data that they do not collect any identifying information. So there's no name that's filled out, no birth date, no nothing like that, and that they're using it in an aggregate setting. So they're not breaking it down into individual responses. This is obviously more at the quantitative level, a little less with qualitative interviews and stuff like that. But that they keep it together in one big group to avoid that. And then also they're not going to then use it to inform future research projects or anything like that. It's more so within the context of trying to release a read on what the community's attitudes and beliefs are in that moment for funding applications, things like that. I think you had something additional you wanted to say.
Yeah, so a lot of times when the communities we work with, it's the data that they're collecting oftentimes isn't sensitive. And so when we're looking more at the broad community level, we're looking more so at just community norms, looking at prevalence of substance use. And so oftentimes also, since it's not a requirement, I think that gets around a little bit of the structure that you need because it's a volunteer opportunity. And like Sydney was saying, we encourage our sites to not collect that identifying data. Now, through the grants that we work with, there are some times where identifiers are needed. And so we will work with our sites to create not nonsense identifiers, but kind of just ways to identify somebody without directly identifying them. So there is that track back, but not kind of getting out any of that sensitive information. Well, we have one last slide. It's just if you are interested, we have some socials that we have resources and things that you can go and locate. They have, we have our IPRC training portal, which we also highlighted earlier in the slide. That has training opportunities and things like that if you're ever interested in following up with any of this.
Thank you so much.
Thank you, Sydney and Connor. Next, I have the luxury of introducing my colleague and dear friend, Mr. Jason Collins from Syra Health. Jason Collins is an experienced public health epidemiologist specializing in infectious diseases. Proficient in data visualization using quantum GIS systems, creating interactive dashboards, informed decision-making, and trend identification. Ladies and gentlemen, please welcome Mr. Jason Collins.
All right, good afternoon, everyone. Again, I'm Jason Collins. Thank you very much, Malcolm, for that wonderful introduction. So I'm going to go ahead and be taking some time to explain a little bit about the CASA, this Community Addiction and Assessment Services. And I'm going to start a little bit with the background of this, but really with us at Syra Health, we are kind of been partnered with DMHA to really kind of find some of these data sources, being able to find some literature surrounding this, the available services, and being able to utilize the reports, the work that's been done by some of the other organizations around, and put it all into one report, kind of compile that together and look at what those insights can bring us. So in September of 2022, the Indiana Behavioral Health Commission released a report on the state of the Indiana behavioral health system. And this report was really outlining several key recommendations for improvement. And one of those primary recommendations was really to utilize this 988 National Crisis Line as a mechanism for really developing a state crisis response system. So this would be so that individuals that were experiencing mental health crises would have that 24/7 access to support and their resources. Another recommendation that came out from this was that we could start to transition Indiana's community mental health centers to federally supported certified community behavioral health clinics,
or CCBHCs. So these CCBHCs are really supported through grants from Medicaid as well as the Substance Abuse and Mental Health Services Administration, or SAMHSA for short. CCBHCs provide comprehensive integrative behavioral health services in the form of 9 distinct services. And that is inclusive, but not limited to your crisis services, your peer family support and counseling, your outpatient mental health and substance use services, and risk assessments, just to name a few of those. And really, CCBHCs have been required to do several things. So one of the things that they must do is operate 24/7, so 24 hours a day, 7 days a week. They have to provide comprehensive care and services so that patients don't have to go ahead and kind of piece together the needed treatment that they need, go through multiple hoops and go to multiple providers to seek what they need. And they also do have to provide care coordination in order to help those patients with being able to navigate these multiple sources and services that they're using. And then they are also required to provide services to those that are requesting for mental health or substance abuse related care, regardless of their ability to pay. The commission also emphasized the need to increase public health services and interventions within the criminal justice system, and they had proposed establishing a Medicaid waiver that would allow for federal reimbursements for services provided to incarcerated individuals. To address the workforce challenges posed in Indiana, the commission was recommending specific types of measures to improve recruitment, your retention, the quality of behavioral health workforce. And these measures would really be about reducing the barriers to licensing, providing tuition reimbursement programs, and also being able to do this to really attract and retain those qualified professionals within that field. And additionally, the report was highlighting the need to further explore the availability of youth services. This would be inclusive of those assessments and of these current programs, and identifying those existing gaps to really ensure that the Indiana youth have access to the mental health services that are needed. Finally, the commission discussed the potential funding options for proposed systematic changes as well. But overall, what we're seeing is that from the Indiana Behavioral Health Commission's report, it was there to really provide this roadmap for enhancing the state's behavioral health care system, addressing both current challenges and those that will be later on identified in the future. And these recommendations are really these crucial steps for being able to go towards a more effective and accessible and comprehensive behavioral health care system within Indiana. So for the CASA model, building on these recommendations from what we just discussed previously, SEOW is using the Community Addiction Services Assessment, or CASA model. And the CASA model is used to assess the current state of your addiction services, identify any types of gaps or areas that are in need of improvement, areas for opportunity, and also provide actionable recommendations to enhance service delivery. The model is essential because it is aiming to serve as this organizing framework for your state agencies, for policymakers, for practitioners, and to evaluate and enhance these various components of the Indiana Addiction Services System, or IASS. This is really within itself a statewide network of addiction resources and services that have programs to provide for assessments and then for cultural competency and sustainability, and they are based off of SAMHSA's Strategic Prevention Framework, or SPF, which is composing of these 7 steps, which we're kind of seeing here, and I won't name them all. But again, cultural competence, sustainability, and these steps are really there to help in that evaluation process of evaluating existing community resources and then those opportunities for further improvement and for intervention as well. So within CASA, the model evaluates 9 specific addiction service domains. The most recent version would be the SEOW Special Topics Report number 4, which will be mostly covered for today. And this would be on the first 2, which are the assessment and the prevention services. So for the assessment domain, this is really using several key surveys. This There was several key surveys that were used to gather this essential data on mental health and substance use trends within the state of Indiana. And this would include surveys such as, but not limited to, things from the Indiana Youth Survey, like INYS, the Adult Gambling Behaviors, Indiana Survey, and the Adult Tobacco Survey, and so on and so forth. But each one of these surveys, they were used to really help understand the needs of different populations and to develop this targeted intervention as well. When we look at the prevention domain, this is really more so including all of the state and federal addiction resources, those services and programs that are really aimed at preventing substance misuse. So this this would be program and resources, drug-free community coalitions, your local coordinating councils, your school-based regional preventional providers. And for the CASA model, what we're really looking at is trying to provide this robust framework for being able to evaluate and also being able to enhance the addiction services in Indiana. And this would be done through systematically assessing the current services, being able to identify gaps, and then making those evidence-based recommendations so those improvements can come to better get the Indiana addiction service system to better support individuals and their communities by improving their substance misuse programs. Okay, so for, again, the assessment domain surveys, and we had briefly touched on this in the previous slide, but the assessment domain features 6 key surveys that collected data on mental health and substance use trends in Indiana, and this was across various populations. So these surveys, such as, again, INYS, we have our Indiana Youth Survey, our ICSUS, ITS, and AGBI. So these first 4 were selected as measures for the CASA model because they were really all specifically related to Indiana mental health and substance use abuse trends, as well as being locally funded by Indiana FSSA. So the adult tobacco survey is actually administered by the health department, Indiana Health Department rather, and then we have YRBS, or the Youth Risk Behavior Survey, and this is administered by the Centers for Disease Control, and this is used to track those behaviors that can have an impact on health in high schoolers. So they're doing this for 9th grade all the way to 12th grade. And they're looking at variables such as sexual behaviors, your substance use, individuals that had experiences with violence or mental health or suicidal thoughts and suicidal ideations as well. And to briefly touch on the adult tobacco survey that was released in 2022, the results had found that almost 29% of adult Hoosiers had used tobacco, with those combustible cigarettes being the most common, but also very closely followed up by the e-cigarettes or the electronic cigarettes. And there were notable disparities with tobacco use across the populations in different groups, which found that households with lower income and then individuals that had a history of mental health or substance uses were more likely to be using tobacco products as well. But the research also did highlight the popularity of flavored tobacco, particularly when we're looking into younger adult populations, and then exactly how much these flavors can actually mask that harshness of tobacco. And 85% of those individuals that were e-cigarette users had actually reported using those flavored products 30 days prior to taking that survey as well. However, in that year, from the 2021 to 2022 year, more than half of those e-cigarette users, and then more than over a third of those cigarette users had actually reported having to have made an attempt to quit as well. Okay, and right here, this is a part of the Indiana Youth Survey. And again, this is dedicated to students in grades 6 through grades 12. And this was aimed to identify those regional trends in youth substance use and mental health. The survey did reveal that there were varying participation rates within each region and among the number of students in schools and in corporations. Really, the overall statewide participation for this was just over 15%. So there was wanting to get more individuals to take a part of this, but one of the things that I did want to point out, and I'll go into a little bit more detail later on, but this is something that would be part of the dashboard. So again, this is information from organizations that had done the surveying, and then what we're doing is being able to take this information, and then we're trying to visualize that and put those on those dashboards that we talked about earlier. So we have those SEOW dashboards where we're having the compilation of TEDS data, Burfist data, and so on. And then this would be something else that would be in addition to that, where you'd be able to interact with that. You see that there are 3 classes where it's students, and then your corporations, and the total amount of schools, and then you see how many individuals would be in that population. And if you were to go ahead and hover over any one of those regions, then that would show the actual participation rate for that region, depending on what class that was as well. So for the local coordinating councils, and this is moving more so into the prevention domain now. So your LCCs actually operate in 91 of the 92 Indiana counties that we have, and they really focus on providing mitigation in drug-related issues through local planning, your collaboration, and with your local stakeholders and so on. And these councils, what they really want to do is to bring together your local stakeholders, your community, to address 3 core areas. And this would be based on your prevention and your education, your treatment, and your intervention, and also your justice programs and your supports as well. So this LCC approach, what it's used to do is really to ensure that the local knowledge and resources are being utilized effectively and impactively to be able to really tackle your substance misuse issues that are specific to that community. And then a funding for LCCs really comes from the local drug-free community fund that is overseen by the Indiana Criminal Justice Institute. And this funding really supports that development of and implementation of something called a comprehensive community plan. And this is something that outlines the strategies that an LCC will take to combat substance misuse in their area. And to evaluate the effectiveness of that, LCCs are required to submit annual comprehensive plans, participate in those focus groups, and then also being able to provide annual reports and complete surveys as well. And then these are the surveys that we saw earlier when we were more so in the assessment domain. And since we covered this out, I can go ahead and skip past this just a little bit. But going back into the prevention domain here, we're taking a look at the school-based regional prevention providers, and they are very needed in order to deliver targeted prevention programs to our Indiana youth Hoosiers. And these types of providers are actually funded by the state through child psychiatric funds, and are very essential in helping to implement prevention programming in schools and communities. So in 2023, organizations such as Lutheran and Hamilton Center, as well as Youth First, were able to utilize this type of funding to offer prevention services for 44 of our 92 Indiana counties. And their work really focused on being able to equip our youth with the skills and the knowledge that was needed to avoid substance misuse and promote mental health wellness. The programs are offered by these providers include a variety of evidence-based strategies and initiatives. These are designed to really address those unique needs when it comes to various education levels for your students. It's looking at providing needs for health education, for life skills training. You're looking at peer resistance strategies, and other types of supportive interventions that would be aimed at really preventing the substance misuses and promoting that overall well-being for those students. And then showing here are 2 maps. On the left, we have a color-coded map of the counties to show I'm sorry, on the left of the slide, but to my right. But over here, we have the yellow, orange, and kind of brownish counties, and this is showing the program. So if it's Lutheran, Hamilton, Youth First, where they are exactly located within the counties. And then if we see in the legend, part of that 44 counties overall, we get to see what the actual aggregate is of that. And then the map here on the left is kind of a copy of the first one. So we're still working with the same counties, but instead this is based on a program strategy. So, is that a strategy that's targeted to the community? Is it for the school and district, or does that somehow have a mix of both of those as well? So this is what these 2 maps here are showing. And then for the drug-free community coalitions, or DFCs for short, these are federally funded and they are dedicated to being able to provide evidence-based prevention services at the local level. So this initiative was really established as a part of a national strategy in 1988, and this was to be able to really equip communities with the necessary resources to respond to your substance misuse related issues through coordinated efforts. So these coalitions, what they do is they engage with a variety of stakeholders. They are inclusive of your faith-based organizations, your community organizations, your businesses, your schools, parents of youth, and other groups to really implement this effective drug reduction strategies. And as a part of the most recent updates, there are currently 23 drug-free communities coalitions in the state of Indiana. Each one of these coalitions do work with the community to develop and implement programs that are aimed at reducing these substance misuses and promoting healthy behaviors. And they also do focus on building local capacity, really in order to address substance misuse by fostering collaboration and having that be done among different sectors within the community. And then we were also able to derive the different addresses of these coalitions. So you can get these from, there's a link that's provided from the drug-free coalitions in Indiana, but also CDC does feature them since it's federally available. And while we can't download that sheet, we can get the address information. So each one of these dots, they are not just randomly placed within a county. It is actually the true coordinate of that location, and that's something that we always like to do. We just want to give the actual positioning of that place as well. But when we look at this map, one of the things that we can see is that there are some regions that may have more and some regions that may have less, but these could just possibly be more areas for opportunity. And now the Federal Substance Abuse Prevention and Treatment Block Grants, or the SAPT-BG, these are really essential in being able to support a wide range of prevention and treatment initiatives across the state of Indiana. These are also administered by SAMHSA, and these grants, what they do is they provide these crucial financial supports to be able to help communities address the substance misuses and the mental health issues in their community. In Indiana, 20% of these block grant groups are actually designated for prevention services specifically, and the funding is supportive of various programs that are designed to really reduce those misuses and then also promote mental health as well, and that's done on a statewide basis. The programs also do include components such as information dissemination and also education. We're looking at alternatives to drug use and substance use, and then also including problem identification and referrals, and then community-based processes, as well as environmental strategies as well. And then in the year 2022, these funds had supported 15 community prevention strategies or subgrants for older adult prevention subgrants and so on and so forth. There are a lot of programs that this went to, but overall, what we see is on a numbers basis, it had served 1.3 million Hoosiers, and that would be inclusive of 136 plus thousand through individual-based programs, and then the other 1.1 million that were impacted through their population-based programs. So right here, we are taking a look at some of the next steps. So one of the things that you had heard in Dr. Devaraj's presentation in the first half of the day is that there are special topic reports that we have, and this is something that takes place through conversations with the SEOW committee to see what items that we need to focus on going forward. So we have completed the first two, which we covered, which were the assessments and prevention domains, but now we also have the remaining domains. So just really working hand in hand with DMH to continue to gather this type of information and making sure that we are able to compile these reports in a way that is comprehensive and really hitting on all of the available resources that we have. So that would be inclusive of, making sure that we're able to see what types of services are being provided, making sure we can get more, more maps and more visualizations to try to find out where those gaps are as well. And then if I can direct your attention back to here. So this is a part of what we were covering in the earlier slides, and what we're continuing to do through our partnership with DMHA. We are continuing as part of this work for SEOW to continue in building these interactive dashboards. So earlier we had the chance to look at some of the data from TEDS, from Burfus, in the form of the charts and the graphs from Dr. Devaraj's presentation. But we're also wanting to make sure that we're really hitting on the mapping efforts too. So we have the ability to show, where these programs are, whether it's the block grants, whether it's your drug-free coalitions. And when, let's say, if you were to log into this and you were to hover over those, and you would be able to see from the DFC side, the actual name and location of that place. And you would be able to just have any other interactive features along with that. But what we're doing is really making sure that we can leverage the information and the tools for the geographic information systems to make sure that we are creating additional maps and additional visualizations based on what we're finding and based on the available resources to show the availability as well as the spread of these services. So again, we were able to look at these kind of on a class-based or color-coded or sometimes chloropleth maps, depending if we're working with numbers and rates, but then also we're also to do more so like dot density maps to see which areas are maybe lacking or maybe where there's areas for opportunity and growth. And as we continue to get data, we will continue to update, and that would be the same for any other dashboards that we have too. So as new data comes, we continue to update and work hand in hand with DMHA to get that done. Well, I would like to say thank you very much, everyone, for your time and for your attention. This would conclude my presentation, and I am happy to take any questions. Thank you. Yeah, so it's okay to contact either myself or Dr. Devaraj for the dashboards. Yes. Let's see. I have my glasses off for today, so I might need some help. Let's see. Yeah, so these ones are all colored in. I can get back to you on that after the after my presentation, if that's okay. Any other questions? All right, well, seeing none, I would just like to thank everyone once again for your time and for your attention, and looking forward to the presentations coming up. Thank you.
Thank you, Jason. I now have the luxury of introducing a fellow Boilermaker as well as my old classmate from Purdue, Ms. Shelby Neerman. Shelby is the Data and Outreach Equity and Surveillance Lead in the Office of Data and Analytics at the Indiana Department of Health. Shelby has had extensive experience utilizing Indiana's statewide syndromic surveillance system, Essence, to monitor for spikes, clusters, and anomalies in overdose-related ED visits as the overdose surveillance systems epidemiologist at the Indiana Department of Health for over 2 years now. Shelby graduated from Purdue University in 2019 with her Bachelor of Science in Family and Developmental Science and received her Master's of Public Health from Purdue in 2021. Shelby is passionate in her efforts to engage with local, state, and national leaders to address public health issues, transform data into acknowledgeable insights, and deliver impacts to improve the health of all Hoosiers. Everyone, please welcome Shelby.
Hi, everyone. My name is Shelby Neerman, as mentioned, and I'm the Data Outreach Equity and Surveillance Lead at the Indiana Department of Health. And today I'm going to be talking with you a little bit about overdose surveillance and how data systems inform public health response. So our mission at the Indiana Department of Health is to promote, protect, and improve the health and safety of all Hoosiers. And our vision is that every Hoosier reaches optimal health regardless of where they live, learn, work, or play. All right, so I'm going to go a little bit into some of our substance use and overdose data, and I know we've talked a lot about that today and touched on a lot of different data points, so I'm hoping that you'll be able to find some insightful information from this as well. So the evolving nature of the opioid epidemic in Indiana has come in 3 distinct waves. The first wave began in the 1990s and early 2000s as a result of an increase in prescribing opioids, resulting in a rise in prescription opioid overdose deaths. The second wave began in 2010 with rapid increases in overdose deaths involving heroin. And then that third wave began in 2013 with significant increases in overdoses involving synthetic opioids. So since the inception of that third wave in 2013, Indiana has seen the number of opioid-involved overdoses continue to rise. This increase was exacerbated by the COVID-19 pandemic in 2020, and you can see in the graph here that it started to increase in 2020, and then in 2021 it increased again, and we're getting down here in 2022, and hopefully will continue to decrease in 2023 and 2024. Let's see. In Indiana, all age groups have been impacted by the opioid epidemic, but the age group of 35 to 54 has continued to have the highest rate of opioid-involved deaths. And in 2022, that rate was 70.9 opioid overdose deaths per 100,000. So additionally, even though opioid overdoses have increased for both males and females, we have consistently seen that males are at a higher risk of an opioid overdose in Indiana. And so from 2014 to 2022, the sex-specific opioid overdose rate increased from 9.4 to 50.83 for males, and increased from 4.4 to 24.2 for females. So from 2017 to 2018, overdose death rates decreased in Indiana among all racial categories. However, from 2018 to 2021, another increase was identified among all racial categories. And this increase has especially been notable among the Black and African American population, specifically from 2019 to 2021. You can see that there was a large increase. And as seen in the graph here, the gap between Indiana's drug overdose rate and the national average increased in 2020 and 2021 during the pandemic. The gap highlights the impact that COVID-19 has had on Hoosiers, increasing the risk of opioid overdose-related morbidity and mortality. And while 2022 mortality data is still preliminary and provisional, the gap between Indiana's drug overdose rate and the national average has decreased. And so now I'm going to talk a little bit more about overdose surveillance and how we use surveillance to identify trends in our data. So the Indiana Department of Health utilizes fatal and non-fatal data on drug overdoses in order to recognize overdose anomalies and changes in overdose trends, such as spikes or clusters in counties or some of our hospital facilities across the state. We utilize this data to understand the circumstances surrounding overdoses in Indiana. We utilize it to identify specific substances causing or contributing to overdose. And then we also utilize fatal and non-fatal data to inform drug overdose response and prevention activities, such as increasing the distribution of naloxone and training for naloxone use, or also preparing emerging drug notifications and or preventative messaging to our partners and stakeholders. Sorry, that is very difficult to read, but if you have specific questions about it, just let me know. The Indiana Department of Health Division of Vital Records is responsible for maintaining and issuing certified copies of vital records, including birth, death, and fetal death certificates for events that occurred in Indiana. Death certificate data is used to track underlying and contributing cause of death, to understand the burden of drug overdoses for prevention. The identified overdose cases are based on ICD-10 codes derived from the death certificate information recorded by county coroners or medical examiners. And as I'm sure all of you know, overdose is a sensitive topic, and findings by the coroner or medical examiner may be subjective or under-investigated, so there may be under-reporting of overdose-involved cases. And in 2023, there was a total of 2,089 deaths due to any drug. So kind of what we talked about earlier, we utilize these ICD-10 codes to categorize our deaths or our hospital discharges into different categories. And we utilize the any drug to kind of lump them all together. But sometimes we separate them out to help us gain different insights. But, you know, we've heard today from different folks that sometimes these, from an outside perspective, might not always be accurate, that sometimes these drugs might actually have other things in them. So I think that that is very important to keep in mind here, is that this is what the ICD-10 codes are telling us. This is how billing folks are categorizing these deaths, but that doesn't always mean that it is 100% accurate. And so that's just something to always keep in mind. And so though this data is provisional and subject to change following the finalization of the data, this is a 21.8% decrease from 2022. So that's a really big win for Indiana. And something else to keep in mind here is that when we kind of break these down even further, 75% of all the overdose deaths involved an opioid, and 70% of all the overdose deaths involved a synthetic opioid. And that's in 2023 thus far. Also difficult to read, but if you have questions about it, it's on our dashboard, so you can also look to that. So the Indiana hospitalizations and emergency department visit data are a subset of data that's compiled from the Uniform Billing 2004 form. This data is supplied by the Indiana Hospital Association under a contract with IDOH. And the outpatient or the ED data contains Indiana residents discharged from a non-federal acute care facility who received emergency services without being admitted to the hospital. And then that inpatient hospitalization data contains Indiana residents discharged from a non-federal acute care facility who were admitted to the hospital. In 2023, there were 15,734 overdose ED visits and 5,119 overdose hospitalizations due to any drug overdose. So similarly to our death data, we're categorizing it by those ICD-10 codes. And nearly 35% of all those overdose ED visits involved an opioid, and 30% of all overdose hospitalizations involved any opioid. So the Indiana Department of Health also uses syndromic surveillance to monitor near real-time suspected overdose ED visits. If you've never heard of syndromic surveillance, it is the ongoing collection and assessment of health-related data that is available in near real time, and it precedes diagnosis or lab results, and it allows us to identify sufficient probability that a case or an outbreak may warrant further public health response. IDOH receives electronic health records from our reporting hospital facilities on average about 3 to 24 hours of a patient's visit to the emergency department, and this data comes to us de-identified through our Essence system. The data is then utilized to monitor and rapidly identify anomalies in visit count and provide situational awareness of changes in suspected non-fatal drug overdose-related ED visits across the state. And because our hospital discharge data must go through data quality checks by the Indiana Hospital Association before being released to us at IDOH, that's often about a 3-month time lag. This data is among our most valuable insight into real near-time data trends on non-fatal overdoses with Indiana, and it is available to both our local health departments and our reporting hospital facilities across the state. And in this graph here, you'll see that over the last 3 years, the number of ED visits captured as suspected non-fatal overdoses. So again, coming in near real time, preceding that diagnosis. So they might have a chief complaint, but they won't necessarily always have that discharge diagnosis confirmed in their record. That continues to increase. There was a very drastic increase that occurred in the second half of 2020 and throughout 2021. And yeah. So together, the Indiana Department of Health utilizes Essence patient records, our toxicology results, our SUITRS data, which is our state unintentional drug overdose reporting system, and then syringe service program data to help monitor overdose trends and emerging substances. Altogether, these sources then provide us with a comprehensive view of the current state of non-fatal and fatal overdoses across the state, and then further highlight areas for intervention. So CDC's State Unintentional Drug Overdose Reporting System, or SUDRS, provides comprehensive data on unintentional and undetermined intent drug overdose deaths collected from multiple sources. Indiana is one of 48 funded jurisdictions across the state. And we're really excited because CDC does have a SUDRS dashboard, and our data was just recently added to that. So go check that out if you're wanting to learn more about this data. But a team at the Indiana Department of Health abstracts data from death certificates, medical examiner and coroner reports and toxicology reports to provide additional details and qualitative data that complements other existing drug overdose surveillance work. So that team at IDOH really sifts through their all of these different death certificates and coroner reports and medical examiner reports and our toxicologies to put together this comprehensive data source. And so we really owe a lot to them because this is a really beneficial source to us when we're trying to really get a good idea of what's happening in real time here at the Indiana Department of Health and throughout Indiana. So the overall goals of SUDRS are to better understand the circumstances that surround overdose deaths, improve overdose data, timeliness and accuracy, and then identify specific substances causing or contributing to the death, as well as emerging and polysubstance overdose trends to kind of help inform our overdose prevention and response efforts. And then here, this is provisional, but thus far, these are the most common substances that have been found in Indiana SUDRS. In 2022, 84% of fatal opioid overdoses captured in this data source primarily involved illicit opioids only. That was followed by 11% of fatal opioid overdoses captured in SUDRS involving a combination of prescription and illicit opioids, and 5% involving prescription opioids only. In 2022, the primary route of administration in fatal overdoses captured in SUDRS was unknown, followed by injection, smoking, and snorting. In 2022, 6% of all our SUDRS opioid overdose cases involved xylazine. And again, just kind of a caveat about SUDRS while we're on this. I'll give you guys some time to look at this graph here. SUDRS is captured from a subset of our counties, and so we don't receive the SUDRS data at any specific time frame. So we could be receiving death certificates or coroner reports or toxicology results months later, or even a year later from when that death occurred. So our data is kind of always updating. So we could receive more xylazine involved overdoses from 2022, and we'll continue to receive 2023 and 2024 as we move along. So our toxicology data is another source of information that we rely on at IDOH to inform our prevention efforts. Samples are run through the Axis Toxicology's base panel, and then completed toxicology reports of decedents are shared with the Indiana Department of Health for review. These reports can reveal substance or metabolites that were found in samples collected from decedents, and then can be used to identify trends in substance use and within the drug supply. Some of the noteworthy emerging substances throughout 2023 were xylazine, bromazolam, metonidazine, and protonidazine, but xylazine was the most common, followed then by bromazolam. The Marion County Safe Syringe Access and Support Program provides free sterile syringes and collects used syringes from people who inject drugs to reduce the risk of infectious disease. The Indiana Department of Health Laboratories conducts drug analysis of residual content of used syringes, which then can detect new substances in the drug supply and then enable prevention services to advise and adapt strategies. In December 2023, of the syringes tested, 71% included a combination of fentanyl and cocaine, 67% included a combination of fentanyl and xylazine, and 64% included a combination of fentanyl and methamphetamine, which just kind of, again, complements some of the things that have continually been said throughout the day. And this is something that I know that the Indiana Department of Health is really looking to expand across the state. So we've been really lucky to see it be really beneficial in Marion County and really provide us with amazing information and data. And then more recently, in March 2024, the top 5 substances present in syringes tested included fentanyl, 4-ANPP, methamphetamine, cocaine, and xylazine. And then again, information like this is just really important to help provide us with information about the drug supply and better target treatment and response. And so to kind of round all of this up for you all, I wanted to kind of touch on some of these emerging drugs and a little bit more about them. So one that we're hearing a lot about is xylazine. Xylazine is a non-opioid agent that FDA originally approved in 1972 as a sedative analgesic for use in veterinary medicines. This is not approved for use in humans. Its signs and symptoms of acute xylazine toxicity may include central nervous system and respiratory depression, hypotension, bradycardia, hypothermia, meiosis, or high blood glucose levels. Acute and repeated exposure to xylazine is associated with clinically significant harms. It can delay the diagnosis and management of polysubstance overdose, and it is also associated with severe necrotic skin ulcerations and interfering with successful treatment of opioid use disorder. Repeated exposure of xylazine may also result in dependence and withdrawal. What we know about xylazine thus far is that it's usually injected, although it can be swallowed or sniffed. It has been primarily identified in combination with both heroin and fentanyl, which kind of, again, complements some of the things that we've heard about today with heroin kind of being fentanyl. And stimulants are something it's also been found with, so combined with methamphetamine and cocaine. And then reports from social media and news outlets suggest that xylazine-containing products may be sold under street names Trank, Trank Dope, Sleep Cut, Philly Dope, and Zombie Drug. And just want to reiterate here that even though xylazine is not an opioid, it is always important to utilize naloxone if an overdose is suspected, because as we kind of have talked about, that a lot of times xylazine is combined with opioids, and so we can address the opioid part, and hopefully then by the time that has happened, providers will be there to further assist. Another drug that we have heard about within Indiana is N-pyrrolidino-edenidazine. It is also known by the street names Pyro M30, and this substance is a powerful synthetic opioid, about 10 times stronger than fentanyl and between 1,000 and 1,500 times stronger than morphine. This substance has been detected in counterfeit drug product within Indiana. And N-pyrrolidino-edenidazine has been confirmed in 21 blood samples and 1 urine sample from 21 postmortem cases, and 17 of those were within the United States. And in all of those cases, additional substances were found in conjunction with N-pyrrolidino-edenidazine, including fentanyl and benzos. And then the reported effects include euphoria, drowsiness, itchiness, nausea and/or vomiting, and difficulty breathing. And similar to other opioids, N-pyro may cause fatal respiratory depression in the person who has ingested the substance. And because it is an opioid, again, naloxone can be used to reverse this as an overdose. And then one more substance I want to kind of bring to your attention is bromazolam. Bromazolam is a novel or designer benzodiazepine, and it has been found on the street under other names such as XLI-268, Xanax, fake Xanax, and dope. Bromazolam is frequently reported in combination with other drugs, and most often in combination with opioids, specifically fentanyl. And then the drug has gone from 4% of the overall novel or designer benzo supply in 2021 to 73% of the supply in the first 6 months of 2023. And emergence comes around the time that some of those similar drugs were temporarily placed on the Schedule I Controlled Substance Act in December 2022. Like other benzos, it can have the effect of loss of coordination, drowsiness, dizziness, blurred vision, slurred speech, muscle relaxation, respiratory depression, amnesia, or death. And as opioids are present in cases of overdose in which this substance is present, naloxone should be administered to reverse the effects of any opioid that may be present. So in conclusion, the evolving nature of the opioid epidemic has further reinforced the significance of surveillance, utilizing overdose data sources across public health, healthcare, and then public safety. Surveillance of fatal and non-fatal data sources is critical in monitoring for trends in overdoses and identifying emerging substances. And we utilize this data to recognize anomalies and disparities in overdose data, which allows us to collaborate with partners and stakeholders across the state to inform drug overdose response and prevention efforts. So with that, does anyone have any questions? If not, feel free to email me or my colleague, Ali. She is our drug overdose prevention epi, and she is also able to answer some questions about some of our data sources as well. Yes. No, utilizing naloxone will not hurt the individual. So we always encourage, even if it's a suspected overdose, just go ahead and administer naloxone. And it's good in the meantime. So typically we encourage, utilizing naloxone, then calling 911, and then when the medical providers do arrive, they can do further assessment and determine if the individual needs to go to the hospital or whatever that may look like. A lot of times we do see that individuals will need multiple doses of naloxone. So yeah, just something to keep in mind.
Next, I would like to introduce our final keynote speaker, Dr. Ashlyn Burns, and I believe there's a special cause of her recognition as she just completed her PhD in Health Policy and Management at the Indiana University Richard M. Fairbanks School of Public Health and is getting ready to start a postdoctoral fellowship with the Indiana University School of Medicine in the Department of Psychiatry. She is a nationally registered emergency medical technician and health services researcher. Her research primarily focuses on access to implementation of behavioral health crisis care, as well as associated patient and population health outcomes. May everyone please welcome Dr. Ashlyn Burns.
Hello, everyone. Excited to be here today and to share a little bit about my research on behavioral health crisis care services with you. First and foremost, I'd like to acknowledge and thank all of my co-authors and mentors on this work who are listed here on this slide. And I would also like to thank the Agency for Healthcare Research and Quality for funding this research and acknowledge the Substance Abuse and Mental Health Services Administration as the organization that maintains the database used in these studies I'm going to be presenting today. So I think there are many folks here who may be experts in crisis services, but I also think there may be some individuals who are new to this area. So I want to spend a little bit of time just talking about what a behavioral health crisis is and noting that a crisis looks different for every person. But in general, it can be described as an acute state related to a mental health or substance use disorder that requires urgent attention. 1 in 8 emergency department visits and up to 15% of all 911 calls involves a behavioral health crisis. And importantly, rates of ED visits related to behavioral health have been increasing at a much faster rate than overall ED utilization. We've also seen rises in anxiety and depression since the onset of the COVID-19 pandemic that are coupled with delays in accessing care. In 2020, more than 12 million adults in the US reported serious thoughts of suicide, and among individuals who access mental health services, more than 17 million reported delays or cancellations in accessing care. So in light of these increasing needs, it's more important than ever to ensure access to behavioral health services. It's also important to ensure access to care because individuals who seek care in the ED for a crisis often do so because they feel as if they have nowhere else to go. Poor access to behavioral health services is particularly concerning for low-income, minority, and rural populations. And under EMTALA, which is the Emergency Medical Treatment and Active Labor Act, EDs must provide services to individuals experiencing an emergency regardless of their ability to pay. And this often means that the ED serves as a safety net for some of the most vulnerable individuals because it is one of the only fail-safe points of access to care in many communities. However, this is problematic because EDs often are not equipped to meet the needs of individuals who are experiencing a behavioral health crisis. Individuals with behavioral health needs desire quiet, safe spaces, strong patient-provider communication, and personalized care. And yet, providers within the ED describe this environment as loud, fast-paced, and overstimulating with little privacy, and that's not conducive to stabilizing an individual in crisis. As such, many individuals who have used the ED for behavioral health crises have reported feeling stigmatized and discharged without anticipated treatment. This means we have patients who are not getting their needs met, which leads to poor patient outcomes, repeat ED visits, longer stays, and overall higher cost of care. Patients with behavioral health needs also experience especially long wait times in the ED, and this is due in part to workforce shortages, workload demands, overcrowding in the ED, and limited training among ED staff in terms of managing patients with behavioral health needs. A few years ago, I was trained as an EMT, and so I had some clinical experience in the emergency department and also volunteered there for a while. And I saw some of these challenges firsthand, and it really made me wonder how we could improve emergency services for individuals who are experiencing a behavioral health crisis. One strategy or alternative to the emergency department is behavioral health crisis care, which is recommended as a best practice to meet the needs of patients. Behavioral health crisis care services may be offered by a variety of different organizations, including hospitals and mental health treatment facilities. And in 2020, SAMHSA published national guidelines for behavioral health crisis care, including a toolkit to help support implementation of these services. And the way that SAMHSA defines crisis care is that it should use a no wrong door approach, meaning that crisis services are for anyone, anywhere, at any time. And a comprehensive and integrated crisis network is truly the first line of defense in protecting public safety and preventing loss of lives. There are 3 core components of a crisis system, and these include crisis call centers, coordinating in real time, mobile crisis response units, and crisis receiving and stabilization programs. In other words, as I think you've heard throughout the day from several other speakers, a comprehensive crisis system should include someone to call, someone to respond, and a safe place to go. Ensuring access to all of these components of care and ensuring that systems are comprehensive is incredibly important to ensure that individuals are navigated effectively and efficiently to needed services. So I'm going to be presenting findings from 3 studies today, and I don't have enough time to go into a lot of detail about each of these, but I just want to give you a sense of what we did and highlight the key findings that have implications for the development of a crisis continuum. So to begin, I'm going to talk a little bit about the national availability of behavioral health crisis care services. So tying this back in with SAMHSA's best practices, there are 6 types of crisis services that are included in SAMHSA's best practice guidelines and are also measurable using the data sets available from SAMHSA. And these include mobile crisis teams, on-site crisis stabilization, walk-in services, crisis intervention teams, peer support specialists, and suicide prevention services. And so for this first study, we used a cross-sectional design, meaning we looked at the availability of behavioral health crisis care services at just one snapshot in time. And this is based on data reflecting 2021 and was conducted at the facility level. So it includes over 9,000 mental health treatment facilities across the US, which is pretty representative because we use the data from the Behavioral Health Treatment Locator tool, which is informed by SAMHSA's National Mental Health Services Survey. And this is a nationwide survey that has over a 90% response rate. So nearly all mental health treatment facilities are represented in this database. And so to highlight just a few of the kind of descriptive findings in terms of service availability, this here shows the number of mental health treatment facilities in percent that offer each type of service examined. And the key takeaway here is that only 6% of all mental health treatment facilities in the US have adopted comprehensive behavioral health crisis care services, meaning that they offer all 6 of the services that I mentioned that are listed here in this table. And additionally, meaning that they accept patients of all age groups, because as I noted from SAMHSA's definition, crisis services are for anyone. So to be considered truly a comprehensive facility, then they would need to offer all of these services and accept patients of all ages. And then in terms of individual services, we found that suicide prevention services were the most common, offered by almost 70% of all mental health treatment facilities, whereas mobile crisis services or offsite care was the least common service offered, with around 20% of all mental health treatment facilities having mobile services. And this here is a map that shows the locations of all of the comprehensive behavioral health crisis care facilities that have adopted all of these best practices. And you can see that they're kind of scattered across the US, with some states tending to have many facilities and others having very few to none that offer comprehensive services. And I just want to note again that this is based off of 2021 data. And given all of the transformations and implementations of new services and recently, it is possible that more facilities have adopted services since this graph was created. And so that's kind of an overview of the key findings from study 1. And then the next study, I wanted to learn a little bit more about the characteristics of the communities that have behavioral health crisis care services, given that we found so few have adopted comprehensive care, in order to see how these communities differ from those who may have some services available but have not been able to fully adopt comprehensive care. And so this was also a cross-sectional study just at one point in time. And rather than looking at the facility level, this study looked at the county level and represents all 3,142 counties in the US. And so we're looking here at the availability of comprehensive crisis services within the county. And again, 2021 data. And so for this study, in addition to the data set from SAMHSA that I mentioned already, we also pulled in some data on the geographic location type from the USDA and some county health indicators from the county health rankings and roadmaps and the area health resources file. And so I know there's a whole bunch of numbers on the screen right now, and I want to kind of break this down to share with you a little bit of what we found here and what we're looking at. So some of the community characteristics that we looked at for this study were reported rates of mental distress as a measure of the community's need for behavioral health crisis care services, median household income, and the percent of individuals who were insured as a measure of the community's ability to pay for services, and then mental health providers per capita as a measure of the available workforce, and geographic area in terms of whether the county was rural or urban. And so for those of you who are interested, these are results from logistic regression models. So the numbers presented here in the table are adjusted odds ratios with 95% confidence intervals. But to kind of just simplify this and tell you the key points here, the two things that were really significant and have implications are that urban communities were significantly more likely to have comprehensive services compared to rural communities. And we found here This was true in the case of both comprehensive services as well as across every individual service examined, that the urban communities were more likely to have adopted services, which is not really a surprising finding given that urban communities tend to have more resources and services available. And then the second key takeaway here is that communities with more mental health providers per capita were also more likely to have comprehensive services, again, as well as all individual services examined. And this is also not a surprising finding given that organizations can't really expand or adopt additional services if they don't have the workforce and capacity to support those services. And so this really tells us the importance of investing in enhancing the capacity of the mental health workforce in order to increase access to care. And then moving to the third study, after looking at availability of crisis care services and the types of communities that have these services, I wanted to learn whether availability of behavioral health crisis care services is actually associated with changes in emergency department utilization or not. And so to recap from the background and introduction, emergency department overcrowding and lengthy patient wait times are longstanding challenges that compromise quality of care. And we know that untreated behavioral health needs contribute to a large portion of ED visits that are largely considered to be preventable. And while behavioral health crisis care has been touted as an alternative to the emergency department, prior to this study, there was very little empirical evidence that establishes whether or not access to behavioral health crisis care services actually reduces ED utilization on a population level. And so the objective of this third study was to assess changes in ED utilization associated with availability of behavioral health crisis care services. And in addition to using the data set provided by SAMHSA, this study also used data from HCUP's state emergency department databases. And this is visit level ED data that includes primary diagnosis as the visit reason using ICD-10 codes. And so that's what I used to measure whether the ED visit was related to a behavioral health need compared to another reason. And so for this study, we use longitudinal data. So we're now looking across several years from 2016 to 2021 and looking at zip codes from 5 states. So the states represented in this study were Arizona, Florida, Kentucky, Maryland, and Wisconsin. And in selecting these states, we were limited by a few factors. Not every state reports data to the state emergency department databases. And then we required that the states included in the study reported data across all years of the study period. And then finally, this data is not publicly available. It had to be purchased using grant funds. And so we selected states carefully in order to maximize the number of states we could include given the budget for this study and tried to ensure geographic representativeness of states from different areas within the US. And so there were a total of 6,012 zip years represented in this study. And so in the first 2 studies, I was looking at availability of services as an outcome, and I'm now looking at availability of services as the independent or predictor variables. So for this study, I created an indicator for 4 different types of crisis services, including walk-in stabilization, crisis intervention teams, peer support specialists, and suicide prevention. And these were the only 4 services that were reported across all years of the study period. So I wasn't able to look at all 6 of the services I mentioned before. So for the 4 services that were included, I first created an indicator for each facility, indicating whether or not they offered that service in a given year. And then across all facilities, that was aggregated to the zip code level to create a count of the number of facilities in the zip code offering each service in a given year. And this allowed us to identify when a zip code first had services become available or had an increase in service availability. So we could look at changes in ED utilization before and after that change in service availability. And so the dependent variable or outcome of interest here, looking at ED visits, is ED visits that were related to a mental, behavioral, or neurodevelopmental disorder. And this is a group of ICD-10 codes that are generally considered to be preventable. And we looked at the rate of visits related to some type of behavioral health need per 100,000 population. And then again, for those who are interested, we did a linear regression model with zip code and year fixed effects and accounted for clustering by zip code for our analysis. And so here I want to show this graph that shows changes in overall availability of behavioral health crisis care services throughout the study period. So each of the 4 services are across the bottom, and the bars show you from 2016 to 2021, the total number of facilities offering each service type. And you can see, especially when looking at walk-in stabilization and crisis teams, that they tend to fluctuate up and down from year to year. So in some years, we have facilities that offer services or new facilities that open, whereas in other years, we have facilities that either close or scale back services. And then you can also see here that in general, we've seen an increase in availability of suicide prevention services over the past few years, as well as increases in the availability of peer support specialists. And so these numbers here are the findings from the model looking at the relationship between availability of behavioral health crisis care services and behavioral health related ED utilization. And the kind of main finding here that is statistically significant is we found the availability of walk-in crisis stabilization services was significantly associated with reduced behavioral health related emergency department utilization. Whereas the other 3 services examined in the study were not significantly associated with any changes in ED use. And so what does this number really mean, or what does this tell us? So to interpret the coefficient from this model, what this really means is that for every additional facility that offered crisis stabilization services, we saw a 2.8% decrease in the mean or average rate of behavioral health related ED utilization. And given the overall rate of ED utilization for behavioral health during the study period, this equates to about 36 visits per 100,000 population. And applying this to the total population size across the states represented in this study, this translates to an estimate of just over 1,500 ED visits diverted per year. And so I also tried to look at estimating the cost savings of these diverted ED visits. And I want to note a disclaimer that these are just kind of crude, rough numbers here, and we really need for future work a more in-depth cost effectiveness and cost savings analysis, but just trying to base some estimates off of what we knew already. And so looking at 2017 estimates, the average cost of an ED visit related to behavioral health was $520, whereas estimates from CCBHC demonstrations have shown that crisis stabilization at one of these facilities can be around $200. And so the difference here of about $320 saved for every ED visit diverted from an ED to a CCBHC or a walk-in site, and applying that across the 1,500 ED visits diverted in this study suggests that the addition of walk-in services offered by a mental health treatment facility can save almost $500,000 in diverted ED visits. And I do want to take a moment to note a few limitations of this study. So we were limited to the information available in SAMHSA's directories, which requires that the organization reports any changes in service availability. So this is one of the most comprehensive resources available and is generally updated monthly, but again requires that the organization report those changes in order for them to be reflected. As I mentioned, in the first 2 studies, I looked at 6 services, but I could only measure 4 of those 6 services in the 3rd study, partially because mobile crisis teams was only reported by SAMHSA beginning in 2020. So I couldn't look back far enough to measure changes related to availability of mobile crisis teams, but I think this is an important area for future research to follow. And then just to recap again, the key takeaways across this body of work. We found that access to behavioral health crisis care, specifically walk-in crisis stabilization services, may help keep patients out of the ED. And yet, looking back at studies 1 and 2, we also found that access to these services is very limited and fragmented across the US. Despite the potential for these facilities to increase access to more patient-centered care, while also saving costs. And some of the factors related to this from study 2 were, again, the workforce shortages, and then we also saw the disparities in rural areas, which really indicates a need to invest in developing the mental health crisis care infrastructure, particularly in rural areas, to reduce disparities in access to services. And thank you again to everyone for listening, and I will take any questions. The first study that I presented is published in Psychiatric Services, so that is available. The second study is just was accepted for publication, so that will be out soon. And then my third study is being revised and resubmitted right now to a journal, so that one's not out yet. But I'm happy to share the links to paper 1, and when paper 2 is available, I can also share that. Distinguish between whether the service was offered like through telehealth or not. It's just whether the facility reported offering each type of service. So from the data, I can't necessarily tell if that service is in person or a telehealth service.
Thank you, Dr. Burns, and congrats once again. Lastly, I would like to call up another colleague of ours and partner in Jeannie Bellman from Indiana Division of Mental Health. Jeannie is the Assistant Deputy Director of the Bureau of Substance Misuse Prevention and Mental Health Promotion at the Division of Mental Health and Addiction. Ms. Bellman has a Master's of Social Work degree and previous experiences conducting outcomes evaluations for child serving agencies. May everyone please welcome Ms. Jeannie Bellman.
Thank you, Malcolm, for that introduction and for keeping us moving so smoothly throughout the day. I would also like to thank all of the wonderful speakers that joined us today to share their knowledge. I know I learned a lot, which I find I always do in this field. So thank you again. At its core, the SEOW functions to collect, analyze, and report on data around substance use and mental health. The SEOW uses that data to make recommendations to DMHA and state agencies. And the SEOW also aims to increase access to data as well as use of data by communities. In an effort to better understand how the SEOW can benefit the work of communities, DMHA will be sending out a survey to community agencies in the coming weeks. If you saw the QR code that was posted earlier, you had an opportunity to also complete that survey. If you missed the QR code and would like to complete the survey, please see one of us and we can get that to you. And the purpose of that survey is really to find out how the SEOW currently aids the work of communities, but then also, and perhaps more importantly, what we can do differently to better meet the needs of communities. So what kinds of data do communities need? And then what kind of resources and products could we create that would then help the communities be able to use that data better? We know that the use of data is incredibly important, both in planning, but also in seeking out funding for the work that you're doing. Again, thank you all for coming to the 2024 SEOW Annual Symposium. We are very pleased and proud to have you all here. Please drive safely on your way home and have a great weekend. We hope to see you again next year. Malcolm, do you have anything? And I'll pass it back to Malcolm real quick.
As Jeannie's said just now, here's that QR code if you would like to take that survey. I just wanted to quickly thank everybody, all of our guests for joining us on this lovely Friday afternoon. You could be anywhere, but here you are listening to these amazing speakers. And thank you so much to all of our speakers. A special thanks. I know I was bombarding you all with my emails these past couple of weeks. So thank you for your patience and your support in coming out today. I also would like to thank, of course, DMHA, Jeannie, Dr. Minnick, Joyce, your team for your help today, as well as the CYRA team, Dr. Rupalanchi, Dr. Devraj, of course, my colleagues, Jason, Brandon, everyone who made this event possible today. Thank you so much. Our registration team outside and the event planning team as well. Thank you. May you all have a blessed Friday and a blessed weekend and enjoy. Thank you for coming out.